Hi, Tasha.
Yash, can I just check that I can screen share and I don't have any issues with my presentation?
Hi, Tracy. This is Bernie. I'm trying to do the same. I don't know who's managing the Zoom.
Yeah, okay. All right. Well,
Yeah. Tasha's supposed to be here 15 minutes till 8. Hi, Nasreen. It's Bernie.
Hi.
Yeah. May I be allowed to try to share my slides?
Sure.
Hi, Amit. Hi,
Hi
Tracy.
everyone. Hello.
Yeah,
Hi
yeah.
Dr. Nasreen. Hi Bernie. Hi Tracy.
Okay, I'm gonna try to share my screen. It won't allow me to do so.
Okay. So I'm gonna show you. Is Jennifer? I'm just looking if the. Okay, if you go down, the World Federation of Peds Imaging has logged on. It says share. There's a small icon right at the bottom. It says 14 participants. Then it's chat, react, share, and more. So under share, let me see if I can share.
No, Nasreen, the organizer has to allow the speakers to share.
Yes,
Yeah.
yes. I'm just seeing if she's on.
Yeah. In the participants, it doesn't show right now the host. None of us is the host, I think.
Okay, so we're gonna just have, I'm gonna email her right now.
Yeah.
Hi,
Thank you.
Joanna. The numbers are climbing up pretty
Hi
soon.
Joanna.
Andres, how are you?
Morning.
Hi Andres.
I'm gonna try and get hold of the Jennifer and on the World Federation of Peds Imaging side, and I'm gonna ask them that we're ready to start.
Hello, everyone.
Hi Mel. Hello.
Hi, Sodi. Good evening.
Hi, Bernie. How are you? Good to see you.
I'm doing well. I'm trying to share my screen. Joanna, which part of the world are you in?
Well, I'm in my office. It's my reporting space in the hospital.
Yeah, UK.
I know.
Hmm.
Very unusual.
Yeah,
Hi, Tracy. Hi, Sam.
hi.
And Amit.
Hi, everyone.
Hi. I think the host has logged in. Bunny, can you try again?
I'm gonna try.
Yeah.
Okay, sharing is not turned on, it says.
Okay.
And-
Yeah, for me too.
Give me
Oh.
1 sec.
We can send request. Yeah.
Okay, just 1 sec. All right, try now.
I can share now. Since I'm the first speaker, I'm gonna give it a shot, okay?
Okay.
Okay. How about that?
Yeah. We can
Okay.
see that.
Okay, so then we'll have other people try. I'm gonna stop sharing. Okay.
Okay, I'll quickly try. Although is it visible?
Yeah, sure,
Yeah.
Amit. Yeah.
Perfect, perfect. I'll stop sharing.
I'm gonna try and share.
That's a lot of folders, Nasrin.
I was going to say that.
I echo the same thing.
Gonna try
Okay,
and share.
I'm going. There we go. Mine's, yeah.
Yeah.
Let me try mine. Can you see it?
Not as yet. Yeah, okay,
Yeah.
now it's fine. Yeah.
All right, thank you.
Has everybody had their run?
Are all the speakers in? Because this may be a
Except
great.
me. I will do my mind trial at the last. If there's somebody else who wants to have a go for it, please do.
I was thinking we should all take a picture.
Yeah, okay, I think we can do that.
Nasreen, we have more people coming in, right? There's Amal.
Yes,
Yeah.
we have more people. I'm just gonna try and share. It's going up. I just had a problem with sharing. Here we go. Is it mine showing?
It says started screen sharing. Wait,
Yes.
yeah, now we can see. Sure.
Okay, perfect.
Okay.
Thank you.
Okay, then I'll also have a go once, okay? Is my screen visible?
Yep. Yep. Now it's visible.
No, it
Okay.
is.
Thank you.
So we've got about 4 minutes still.
7 minutes in my clock.
Yeah, 7 minutes.
Forget about the other room.
We paid for it. Somebody's mic is on. Nasreen, you can start with the introduction when the time comes, not now at the exact time. You start with the introduction, then I will do a brief one. And then, as discussed, I'll introduce the first three speakers, and then is mind talk, and then you can introduce the rest of them. Is that fine?
Thank you so much.
Okay.
Hi, Saudi. I timed mine at 13 minutes. Depends on how fast or slow I speak, but
No,
yeah, I
it's
timed.
fine. Not to overstress for the time, but I mean, if we stick to time, only then we can finish on time. So if somebody has less time, then probably we'll skip the Q&A sessions for that particular talk. I mean, that's all right.
Yeah, Perfect. Yeah.
Because this symposium or the imaging session, virtual symposium, is not meant for a Q&A session as such. But if there is some time, it's good to have one or two questions. Otherwise, we can just go to the next speaker, you know. That's the plan.
Okay. Sounds good.
Sorry, can I just check? Are we going to record the lectures?
It is recording, yes.
Okay, so that's good. So we can put it later on the website. Thank you.
Sure. Nazreen, I don't know if you saw my chat. I did make you the host just so when I need to jump off, you will have the ability to stay on and the meeting can continue.
Perfect. Thank you.
Thank you.
Thank you, everybody, for joining the symposium. We have speakers from 5 continents today, which is really remarkable.
8 o'clock.
Yeah, I think Nasrin, you can start.
Okay, thank you. Thank you. Good morning, good afternoon, or evening, colleagues, depending on where you are in the world today. Today, we gather to mark World TB Day. We are reminded that tuberculosis remains not only a disease of the past, but a pressing reality of the present, one that continues to challenge our healthcare systems, our communities, and our own collective resolve. Despite advances in diagnostics, treatment, and prevention, TB remains one of the leading infectious causes of death worldwide. Behind every statistic lies a patient, a family, and a story, often marked by delayed diagnosis, inequity, and vulnerability. Can you mute, please? Behind every statistic lies a patient, a family, and a story often marked by delayed diagnosis, inequality, and vulnerability. This is particularly true in children, where the disease is often silent, under-recognized, and difficult to confirm. World TB Day is not only a moment of reflection, but a call to action. It challenges us as clinicians, researchers, and advocates to strengthen our efforts in early detection, to embrace innovation such as molecular diagnostics, and to ensure equitable access to care for all. Today's symposium brings together expertise pediatric radiologists from 5 continents, reinforcing the importance of global collaboration in addressing pediatric TB. Let this be a space for shared learning, critical discussion, and renewed commitment. As we open this meeting, let us reaffirm our shared purpose to move closer to a world where TB is no longer a cause of suffering or loss, but a disease of Thank you. Prof. Sodi?
General medicine lang sila, hindi sila specialist sa goiter. Kasi
Thank
mag-emergency
you.
tayo.
I'm going to start by requesting
Kami
everybody to
matatawag na
kindly mute themselves
espesyalista,
first.
nakatulad niya. Ay, delikado.
All right. Thank you to the host for, I think somebody mic was on. Thank you, Nasreen, for setting the ball rolling. A very warm welcome to all my colleagues across the globe. And on this occasion of World TB Day, it's indeed an honor and privilege to welcome you to this virtual symposium on pediatric tuberculosis imaging under the aegis of World Federation of Pediatric Imaging. Today's symposium has been thoughtfully curated to reflect both the depth and diversity. We will traverse critical themes from global advocacy and the pressing need to strengthen pediatric TB imaging pathways to the evolving roles of ultrasound, MRI interventions, and finally to the exciting frontier of artificial intelligence, which holds a great promise to transform access and accuracy in resource-constrained settings. We, of course, have seen in the past the persistent gaps in access and awareness, making discussions like these both timely and essential. I warmly acknowledge my co-chair Nasreen, who is heading and leading this program, and thank all the speakers and participants for being part of this important initiative. Over the next 2.5 hours, I encourage you all to stay engaged, focus, participate, and use this platform not to just learn, but to exchange ideas and perspectives. Thank you all, and let us now begin the show. Our first speaker is none other than Dr. Bernie Lea for Philippines, who actually needs no introduction to this field of pediatric tuberculosis imaging. Professor Bernard Lea happens to be the past lead for the TB lead for the World Federation of Pediatric Imaging. He is also the founder president of Philippine Society of Pediatric Radiology, trained extensively in the US in both Cincinnati and the Cleveland clinics initially. He is now the section head for pediatric imaging at St. Luke's Children's Hospital. Dr. Laya will be speaking on global advocacy for pediatric TB imaging. Over to you, Bernie.
Thank you very much, Sodi and Nasreen, for inviting me to speak in this quite global initiative. Thank you to the World Federation of Pediatric Imaging, led by a good friend, Dr. Nicholas. Okay, so my topic for today, if I would now share it, is entitled Global Advocacy for Childhood Pediatric Imaging. I should start. And for my objectives, okay, we'll present the global TB burden. We'll discuss challenges in diagnosis of TB in children. And of course, we will highlight the role of chest X-ray and other imaging modalities in TB treatment decision algorithms. And of course, emphasize the need to elevate the use of medical imaging from a supportive role tool into an advocacy. There are actually 10.7 million who got the disease, reported to have illness from TB globally in the year 2024, and of which 390,000 new cases of drug-resistant TB. This is an enormous TB burden. And of course, the determinants have remained under nutrition, alcohol use, smoking, HIV, and diabetes. 1.23 million or 11.5% died from TB globally in the year 2024 alone. So TB is the leading cause of death from a single infectious agent and one of the top 10 causes of death worldwide. In children, the burden of TB is just as astounding. Approximately 1.2 million cases in 2024 alone. This represents 11% of the total global TB burden for 2024. Keep in mind that although in 2024 there's 10.7 million global TB new cases, there's actually an estimate that the quarter of a global population have been infected with TB. So this means that there is a detection gap. And this is especially seen in children where
Start na yung TB. Start na.
there's actually increased disease burden. Could we mute our microphones, please? In children, it represents 11% of TB burden, but keep in mind 15% of all TB deaths are reported in children. This means that there is a disproportionate gap, that children die more of TB when they develop the disease. And this is largely due to the diagnostic failure. And once we know that there is misdiagnosis or non-diagnosis, there's delayed treatment, complications, and even death. And the more severe the disease process in children, they have increased risk of transmission. Diagnostic challenge in children remains the same because, of course, the symptoms such as cough, fever, and weight loss and failure to thrive overlap with common childhood illnesses, including pneumonia. In children, there's also low bacterial load. Therefore, the traditional sputum smears are sometimes negative, and this is often the case. In children, sometimes it's difficult to collect the samples. Young children cannot expectorate, and gastric aspiration or induced sputum are are invasive and requires a lot of training in the case of those people who trying to get those samples. In adults, molecular diagnostic tests have high sensitivity, but in children, it's only moderate sensitive. And of course, in adults, the TB is just very obvious. You see fibrocavitary disease in adults, in upper lobes, in children, lymphadenopathy and lung disease could be subtle and could be difficult to diagnose. I want to present this map to you. This is by WHO in 2018, and this shows that in children who are very vulnerable, once they are exposed and they have good access to healthcare, they could be detected if they have the infection, and therefore they could proceed to have preventive treatment. However, a lot of children do not get the access to healthcare, and once they get infected, they don't even go to the hospital or access healthcare unless they get the disease, feel ill, and that's the only time they get diagnosed and they get treated. So that's a disconnect as well. And of course, there's a high number of patients who are also misdiagnosed or undiagnosed. And when they become symptomatic, that's the only time they get to access the healthcare system. So there is now a shift toward treatment decision algorithms. We can no longer wait for bacterial confirmation. Sometimes we have to start treatment based on imaging and symptoms without laboratory confirmation. So X-ray is now on the forefront. It is a very important element in treatment algorithms for screening patients, identifying them even though they are asymptomatic. And for those who are symptomatic, we could do X-rays and other imaging tests, and there's a scoring system for this. It is therefore very important to detect airway compression by lymph nodes, to differentiate TB from other infections of the lung, including bacteria, and help determine the type of management based on severity of disease as we see it on medical imaging. This is a copy of the page from the operational handbook of TB, particularly in management of children and adolescents. I would like to point your attention to the scoring system that is used. Signs and symptoms are graded +1, +2, +5, etc. And chest X-ray also has a scoring system. If the sum of symptoms and signs and chest X-ray are or greater than 10, children are, supposed to get appropriate TB treatment. But if it's less than 10, they get followed up and, they get managed, and decision will be made after the follow-up. To understand imaging, we have to understand the infection and how it comes about. So we need to understand pathophysiology before we understand TB imaging. So when somebody gets the infection, pardon me, for example. When can you turn that? Pardon me, my computer just, I'm gonna stop sharing for a second. Sorry about this. So, could you take over for a second?
Sure. When you take your time, in this era of AI and advances in imaging technology and all technology, the computer glitches are always there. But I'll use this time for the audience. If you have any questions, kindly type in the chat box. depending on the time we have left at the end, we shall take up all these Q's and A's and the questions at the end of this symposium, right? After all the speakers have spoken. So, Bernie, whenever you're free, you can join us once things get resolved, right?
Sorry, my computer locked up, so I'm sorry about this. We could proceed with the next speaker. I'll pick it up right after.
All right, no worries. So, because of technical glitch, we have a slight change in the program. So we have Nasreen now, who's the second speaker. Otherwise, take over from now, and Bernie can join us subsequently. So our next speaker is Dr. Nasreen Mohammed herself, who is the TB lead for World Federation of Pediatric Imaging, and who is heading this symposium as well. She is also the ESPN AI Task Force member, has a very long CV, but just in interest of time, I'm going to cut it short. She is the professor and academic head of radiology at University of Witwatersrand, and she's going to speak on pediatric tuberculosis chest imaging. Over to you, Nasreen.
Can you see my PowerPoint?
Yes.
Okay. Thank you so much for
Yes.
that kind introduction. And I would just like to thank the World Federation of Peds Imaging, headed by Dr. Jennifer Nicholas, for supporting this initiative on Global TB Day. So if you look at the pediatric TB map pre-COVID pandemic, it is actually Africa, Asia, and areas of South America that had the highest burden of disease. And then post-COVID pandemic, 2024, by the WHO, this map looks very, very similar. Again, it's sub-Saharan Africa, areas in Asia, particularly in the South, and areas in South America that has still very high rates of TB. So the microbiological diagnosis of TB is very difficult, as alluded by our previous speaker. And this is due to the porcibacillary nature of childhood TB. In fact, sputum sphere microscopy and gastric washings have yields of 4 to 7%. TB cultures have better yields of 30 to 40%, but it takes time, like 4 to 6 weeks. GeneXpert is really dependent on the sample, but very importantly, GeneXpert, especially in children, has low sensitivity, but much better specificity. And due to the difficulty in obtaining microbiological confirmation of TB in children, the diagnosis often relies on a combination of clinical and radiological findings. The role of imaging in thoracic TB is for the diagnosis, assessment of response, and the detection of complications. Thoracic involvement in TB can be pulmonary, lymph nodal, pleural, or a combination of these. Chest radiographic findings specific for TB are hilar, paratracheal, and subcarinal lymphadenopathy, miliary nodules, cavities with surrounding consolidation and thick walls. Airspace consolidation is a very non-specific finding in primary pulmonary TB, but in combination with hilar or mediastinal lymphadenopathy, it may be associated with pulmonary TB. The key diagnostic imaging modality for primary care and emergency services in low-resource countries are chest radiographs and chest ultrasound. Together, they can meet 70 to 80% of the imaging needs of low-income countries. However, while intrathoracic, mediastinal, and hilar lymphadenopathy is the radiological hallmark of pulmonary TB on chest radiograph, a very important limitation is the poor inter-reader agreement. In fact, some studies show kappa as low as 0.2 to 0.4. So this is just a proposed schematic we did demonstrating the area of hilar and mediastinal lymphadenopathy. The next case demonstrates the hilar and mediastinal lymphadenopathy in addition to the right-sided complex. The donut sign is visualized on the lateral chest radiograph and is formed by the normal right and left main pulmonary arteries, the posterior aspect of the aortic arch anteriorly and superiorly, and the hilum and subcarinal lymphadenopathy inferiorly. The radiolucent center is formed by the trachea and the upper lobe bronchi. The donut sign represents superimposed hilar and subcarinal lymphadenopathy. So we did the schematic, which actually just makes it simple to show lymph nodes anterior, inferior, and posterior to the bronchus intermedius, completing this classic donut sign. And this is the example that I showed with the hilar nodes. And you can see that's lymph nodes anterior, inferior, and posterior to the bronchus intermedius. And on CT of the same patient, you can see this necrotic rim-enhancing nodes demonstrating the donut sign. This is an example of very significant hilar nodes. You can see these lobulations in the hilum with the classic donut sign. In addition, you can see the consolidation and the thick-walled cavity. And these are really the classic features of TB that you don't want to miss. Another example of bilateral hilar lymphadenopathy. And you can see that the obscuration of the hilar point due to the lymph nodes. This is an example of larger interstitial nodules, some that have coalesced, and on lateral there is also hilar lymphadenopathy demonstrating the donut sign. An example of a con complex on the right upper lobe and a pleural effusion. And this is an example of diffuse nodular infiltrate that has actually coalesced. In areas it's formed consolidation. There's obscuration of the right heart border. And in addition, this child had lymphadenopathy. And this is an example of a massive large right pleural effusion. However, there is no mediastinal shift to the contralateral side, and that is due to collapse of this underlying lung. You can see the bronchus cut off, and hence no mediastinal shift. An example which we don't really see that often of cavities in a child. This entire right upper lobe is completely destroyed. There are multiple cavities. There is shift of the minor fissure upwards, and you can see this. So in this case, the patient is very important to identify because this is a potential for complications, example, fungal infections, re-aspiration, etc. And this patient had a successful right upper lobe lobectomy. And this is an example of a pericardial effusion, massive enlargement of the cardiothoracic ratio with a globular-shaped heart in keeping with a pericardial effusion. Chest ultrasound, I'm not going to discuss it in detail, just to say that my colleague will be having a lecture, that it's very useful, especially in the mediastinum, to look at lymph nodes and vessels. And this is an example of a patient with the probe into the suprasternal notch. And you can see how by putting in the color Doppler, you can differentiate the lymph nodes as hypoechogenic, not taking up color, and differentiate from lymph nodes. And it's really useful to evaluate for lymphadenopathy in the superior mediastinum. So my colleagues, Dr. Concepcion et al., developed imaging recommendations and algorithms for pediatric TB. And this was when patients should be referred from a chest X-ray to further imaging like CT chest as well as MRI. And I think it's really useful just to highlight the indications of thoracic CT, persistent worsening of airway obstruction, unresolved collapse, suspected bronchiectasis, complex pleural disease, atypical opacities, and disease in more than one lobe. Technique, we use ultra-low dose protocols, a MINIP for central airways, and MPRs with contrast for vascular and pleural complications. The characteristic findings of CT suggestive of active TB is obviously lymphadenopathy. You can see the classic enlarged lymph nodes in the mediastinum and hilum with central necrosis in the rim of peripheral enhancement, which may or may not have calcification, consolidation. A lobular pattern of consolidation favors TB, but is not specific. Ipsilateral peritracheal or hilar lymphadenopathy, thick wall cavities, central lobular nodules can be typical. You could see the tree and bud appearance, and then clustered or miliary nodules. Patient with enlarged superior mediastinum, you can see the widening of the superior mediastinum. In this patient who is 1 year old, a CT chest was done, and the CT chest demonstrates both an axial and coronal, demonstrates low density anterior superior mediastinal lymph nodes, which are encasing the superior mediastinal structures. There is areas of calcification within these lymph nodes, which are punctuate. On the coronal, MPR, it demonstrates deviation of the trachea to the left, but there is no obvious airway compression. So CT is really important to actually look at that airway. This is another example of significant lymph nodes in the posterior mediastinum as well as the hilum. You can see the rim enhancement and in the superior mediastinum, and you can see this area of necrosis in the right upper lobe with the underlying dense consolidation. Examples of complications of TB. This is another example of TB. The frontal chest X-ray shows dense consolidation in the right upper mid zone. Note the displacement of the trachea to the left. The lateral chest X-ray demonstrates bulging of the horizontal fissure and soft tissue density of lymphadenopathy around the carina. And then we have a CT. The CT demonstrates multiple hypodense lymph nodes, as well as consolidation in the right upper lobe with caseous necrosis. The next example is of a miliary TB. You can see that it doesn't follow any specific anatomical pathway. It's just diffuse miliary. There is no sparing of the peripheral 1/3 of the lung. And on the right, there is a silhouette sign. And the CT demonstrates this diffuse miliary nodules in bilateral lung fields, classic of miliary TB, which actually indicates hematogenous spread of TB. And that's when you want to do abdominal sonar to look for complications. The next example demonstrates multiple central lobular nodules in the right posterior segment of the lower lobe. And these have a tree and bud appearance, which is suggestive of endobronchial TB. There's also some central lobular nodules in the posterior segment of the left lower lobe, as well as consolidation in the medial segment of the middle lobe. Example of a split pleural sign where there is enhancement of the visceral and parietal pleura in a patient with complicated TB. So just to touch on, AI, we have a very interesting talk, but we are doing a lot of research looking at chest X-rays and AI. And MedGemma is a software that was released by Google. It's open source. And it's been trained on pediatric and adult chest X-rays in the USA. So essentially, when we tested MedGemma on this chest X-ray with a large pericardial effusion with a globular-shaped heart, you can actually see the findings from MedGemma. it gives a normal appearance of the heart and lungs, and they cannot elude the reason for the shortness of breath. And they also say that there is no pleural effusion or pericardial effusion. So you can see how important that, we've got a lot of new softwares that are coming out, how important it is to actually have a specific training of AI in the pediatric setting. And then we are currently working on radiomics and TB on chest X-ray. And I think this is a very interesting field. My colleague will be discussing this in further, but we have made a significant progress looking at texture maps and shape analysis with nodal segmentation. So I think this is very important in the future. So the next part is TB iris. Immune reconstitution inflammatory syndrome refers to a collection of inflammatory disorders commonly due to infection that may manifest after the initiation of antiretroviral therapy. Approximately half of iris, both adults and peds, are due to Mycobacterium TB. Paradoxical iris is worsening of a previously diagnosed or partially treated infection, while unmasking iris refers to clinical features related to a previously undiagnosed asymptomatic or subclinical infection. The prevalence of iris in children in sub-Saharan Africa is low. In the study that we did, the THINK study, we found that the incidence was 4.8% of paradoxical TB iris in children under 8 years at Chris Hani Baragwanath. A global consensus on iris in children has not been reached, but should be considered if ART has been recently initiated within the last 2 to 6 weeks. There is a decline in HIV viral load with a significant rise in the CD4 count, and there is local or systemic inflammatory changes categorized as paradoxical iris or unmasking iris. The degree of iris really is dependent on the degree of immune suppression, that is the level of the HIV viral load as well as the CD4 count. But because antiretrovirals are initiated in our country in all children, we have seen a decrease in iris. As I said, 50% of iris is due to TB. Other important organisms is BCG, CMV, and then importantly, non-TB mycobacterium. Example, Mycobacterium avium. So it really is important to consider. The most common findings on chest is new or worsening, hilar or mediastinal lymphadenopathy, which may cause tracheobronchial compression, which is a complication, and hence a CT would be indicated. Worsening or new airspace consolidation, pleural effusions, reticular infiltrates or nodular infiltrates. In the abdomen, it's ascites, abdominal lymphadenopathy, and splenic microabscesses. And the CNS manifestations are really very uncommon, but these include TB meningitis and tuberculomas. So this is an example actually from the THINK study. At baseline, the patient had bilateral hilar lymphadenopathy, and there was silhouetting. You can see the obscuration of the right heart border. The patient had initiated TB treatment 2 weeks before the antiretroviral therapy, but 2 weeks after the antiretroviral therapy. So the patient was on TB treatment for 4 weeks at this time. You can see significant worsening. In fact, there's right middle lobe collapse because of the enlargement of the hilar nodes, and the infiltrate has increased. But the patient was continued on the antiretroviral therapy and treated appropriately, and they improved. So very, very important to look at your baselines and follow up in patients for iris. This is another patient. We don't have the initial imaging, but the patient presented with severe respiratory distress, was not on TB treatment at the time. And you can see the large necrotic lymph nodes. In fact, it's surrounding the carina. There's 360-degree surrounding of the right main bronchus on the right. And you can see the dense consolidation and significant lymph nodes in the posterior mediastinum. So this patient it was an unmasking TB, whereas the previous patient was a paradoxical TB because it was previously diagnosed and it got worse, and this was never diagnosed and it unless it was missed. And then the last patient presented with a headache and severe meningism, also had initiated a TB treatment at around about 5 weeks prior, and was on antiretroviral therapy. And when we did the MRI, the CT, you could see the diffuse leptomeningeal enhancement with the obstructive hydrocephalus and transependymal edema, suggesting that this was an acute TB meningitis. And essentially, because the patient was already treated for TB in the past, not for TB meningitis, but TB of the chest, this was a paradoxical iris because it actually got worse with the antiretroviral therapy. The patient had to actually go in for a VP shunt. So I'm not going to really go on to the advanced imaging of TB. It's a really exciting topic. My colleague, Dr. Sodi, will be discussing it. But I would just like to highlight that it is an important area of research, but due to significant limitations, in fact, the countries with the highest burden of disease do not have access to MRI. I would just like to say that in early TB, it's
I think
often
I'm going to
difficult to
request you to wind up.
Sure. So in conclusion, TB remains an important cause of infectious disease in the chest and is associated with substantial morbidity and mortality in the pediatric population, particularly in low and middle income countries. Evidence-based imaging algorithms, thoracic and extrathoracic, are important for standardized care, initiation of treatment, and prevention of long-term morbidity. CT improves detection of complications, including airway stenosis and bronchobronchial TB. While ARV have revolutionized the care of HIV-infected children, antiretroviral therapy has side effects and potential adverse consequences, including IRIS. IRIS is typically classified as either unmasking or paradoxical. However, this distinction can be difficult as both forms may coexist. It may be difficult radiologically to distinguish IRIS in children from TB and other opportunistic infections. So radiology must be interpreted in combination with clinical and lab findings. Thank you so much. I would like to invite you to review some of our papers and some of our original studies that we published. And thank you so much.
Thank you. Pediatric tuberculosis chest imaging. You've covered the entire spectrum very nicely. Some very excellent images coming up during your talk. Thank you. So we can go back to Dr. Bernard Lea. Dr. Bernie, can you join us now?
Yeah, sorry about the technical glitch. So I'll pick it up where I actually left off. So we'll talk about, I was talking about the role of medical imaging, that there is now a shift towards the treatment decision algorithms. So we cannot wait for bacterial confirmation anymore. We start treatment based on imaging and symptoms, even without laboratory confirmation. So chest X-ray is more important than ever for treatment algorithms, both in screening and in diagnosis. And foremost, we would like to see airway compression by lymph nodes to differentiate TB from bacterial pneumonia and other lung infections, and help determine the type and management based on the severity of lung disease as we see it on chest X-ray. To understand chest imaging, we need to understand pathophysiology. So if somebody coughs and the patient inhales the mycobacteria multiplies within the lung, and this causes significant inflammation and irritation, not only of the alveoli, but also of the airway. And of course, as they multiply, the mycobacteria travels into the lymph nodes, they get enlarged, and they cause significant inflammation and airway disease. So we need to understand that Gone complex is not just lung lesion, but also lung lesion and lymphadenopathy together. Once the microbacterial, the bacilli are dormant, they could reactivate and progress into active TB disease. Sometimes this is subtle in chest X-ray, so we need to understand how pathophysiology and imaging correlates. In TB infection, remember that they are not necessarily symptomatic. So you could see a lot of normal chest X-ray, and sometimes lymph node could be there without compression on the airway, so they could still present without symptoms. And of course, they could have symptoms. They could have lymphadenopathy with lung nodule or a calcification in the lung. So these patients may not have symptoms at all, and calcification in the lymph node also. So with infection, they could become an active disease. So as we know, the mycobacteria could travel not only in the lung and the lymph node, but could also go to the pleural space, in the pericardium, and the lymphadenopathy could cause significant airway compromise as well. So on radiographs, first, there's failure of cell-mediated immunity, so they cannot contain and eradicate the infection, so infections become the disease. And this happens in immunocompromised children, particularly the undernourished children, less than 4 years of age. And depending on the symptoms and age and degree of disease involvement, that's what we see on the radiograph. So the spectrum of disease progression could be nodular pattern, cavitation lung disease. It could be lymph node compression on the airway, causing hyperaeration or even atelectasis. It could be a combination of lung disease and lymph node disease, or disseminated pattern, or even a combination of all these patterns. So on radiographs, you could see significant lung disease with lymphadenopathy. There could be cavitation of a significantly abnormal lung opacity. There could be destruction of the lung, and of course, miliary pattern. Now, ultrasound plays a very important role now more than ever because we know the anatomy and we know the expected locations of lymph nodes, particularly in the hilar and paratracheal area. And if we know anatomy and we know the locations where lymph node could be, we could do ultrasound. This is why mediastinal ultrasound is effective for TB diagnosis. Of course, we know the CT scan is the gold standard for lymphadenopathy and its complications, particularly airway compression. The lymph node with calcification can erode on the airway, as we see on these images. And of course, CT scan describes the type and extent of lung disease. It could be nodular with bronchiectasis, cavitation. It could be miliary pattern. We could also see pericardial disease and, of course, chest wall and pleural extension of the disease. This would also be described later by our colleague, MRI for TB diagnosis, because MRI has great soft tissue detail. We could see lymph nodes, pleural disease, if it's simpler pleural effusion or empyema. We could see cavitation and fibrosis. And we all, of course, know that MRI is great for TB spondylitis or Pott's disease and its impression on the spinal cord. MRI, in fact, is the imaging tool that's best for diagnosis of TB of the musculoskeletal system. There are challenges and, of course, proposed solutions. The problem is there is very high interpretation variability. So we need to standardize training in interpretation, even for chest radiograph. We want to use lateral views, particularly in younger children, those 10 years old and below. The problem is there is resource constraint. There's limitation of chest imaging machines in those areas that need it most. Therefore, we need to advocate portable digital radiographs because in the end, this is cheaper, less chemical use. We also need to advocate point-of-care ultrasound, which is excellent for lymphadenopathy, pleural disease, pericardial disease, and abdominal TB. Of course, there are also technology gaps. Computer-aided detection is now here. And thank God for WHO, who has already approved some AI applications, and there are more that they are still checking at the moment. Teleradiology networks is very important also because it connects rural clinics to global experts. And the World Federation of Pediatric Imaging also takes the lead in doing teleradiology, connecting with areas that are underserved. Now, it is a call to action. The best diagnostic tool is the one that the patient can actually access. Keep in mind that a clear chest x-ray does not always rule out TB, but keep in mind that a missed lymphadenopathy without a chest x-ray, without a chest x-ray, we don't see lymphadenopathy, we're missing a person's life. So we need to elevate imaging from supportive tool to frontline diagnostic necessity, that radiologists and clinicians must move from passive reporting role to an active advocacy role, that we must ensure imaging is integrated early in the pediatric triage. Remember the pillars of advocacy. Number one, we standardize imaging studies, interpretation, and processes in all levels of national TB pediatric algorithms. We need to upskill ourselves on basic chest x-ray and focus interpretation. And we need to invest funding digital imaging infrastructure and pediatric specific AI research. This is all. These are my references. For those who want some references, you can just email me at bernilaya@gmail.com. Thank you very much.
Thank you, Dr. Bernard Laya, for an excellent presentation on global advocacy to pediatric TB imaging. It is just the right talk to set the ball rolling on this day of World TB Day. Moving on, in the interest of time, I'm going to invite the next speaker, Dr. Andres Garcia, who's a very good friend of mine. And Andres actually has been the past president of World Federation of Pediatric Imaging. And hello, Andres, can you hear me, or is my microphone still bad?
Hello. Good morning, everyone. Good evening. I unfortunately I wasn't hearing properly. Now I understood your last phrase, Kojajit.
All right.
Hello.
Over to Andres for his talk on role of ultrasound in TB chest.
If I may share my screen and maybe I can read the chat.
Yes, sure. Go ahead.
Okay. Can you see my screen?
Yes.
Okay.
Andres, go ahead.
Sorry. I'm not understanding Ujajit. Thank you very much again. Well, it's a real pleasure to be with all of you today here. I'm Dr. Andres Garcia Baice from Uruguay. Well, first, there's no conflicts of interest, and what we're gonna talk about in this lecture, mostly about some technical issues, some of them basic semiology of ultrasound in chest regarding pleural cavity, lung, semiology of normal lung and acute alterations, because from what I always see, many radiologists don't usually perform and are not familiarized with lung ultrasound signs. So for some of you, it may be basic that part, but for some others, maybe I hope a push towards starting to getting familiar with the method and its applications. And then we're going to talk about the ultrasound with thoracic tuberculosis itself. So first, pediatric chest ultrasound in general it has the big advantage of having much better acoustic windows than adults regarding the observation of the mediastinum through various windows, and also the lung, the pleural, and the extrapleural space that is important in tuberculosis. The first thing we look at is, of course, the pleura, and regarding the pleural effusion, we have the standard patterns of simple pleural effusion and complex pleural effusion. That is quite basic. That is complex effusion is just any kind of effusion that's not anechogenic, and those are the things we should be looking for. In the dynamic, the sign of the jellyfish in case of a big effusion with the floating parenchyma of the lung. In case of a complex types of pleural effusions, we can see septa of fibrin that goes from one pleura to the other. We can see moving septa. The more septa, the more loculated that the effusion will be. Thus, the lung can be completely incarcerated. This is quite frequent in tuberculosis. Another type of complex effusion may be hemogenically echogenic. That's also a complex type, but with no visible septa. One thing we can apply to pleural effusion is the use of Doppler. That's another auxiliary mode. We can see when there's free moving liquid fluid in a free cavity, we see the liquid moving towards and away from the transducer, changing colors. That's useful too to see if it's loculated or not. Every time we assess the pleural effusion, it should be a standard for a basic report to make all the measurements in all the phases, and also in the usual puncture site. That's normally a fifth intercostal space posterior axillary line in case the effusion is not loculated. So we make all the measures in all the phases. One particular phase would be the subpulmonary effusion that many times gets more or less ignored. When it should be measured too, it may be somehow hidden. There are various formulas, of course, for the measurements of pleural effusion. The thing is, in case you use these formulas, you should stick to one of them, because they are not validated in children. But in bigger children, you could, with some confidence, use it to know how many milliliters of fluid you have, and they are normally more accurate in an upright position. But take care with what you do. Always use the same formula. Another thing is regarding the inter-observer variability, that you should always measure all the pleural and all the fibrin deposits in both sides of the effusion, and not making a measurement as in this case. This is the correct measurement. This is the wrong measurement. Of course, the second biggest application of ultrasound is the parenchymal consolidation, with a classical solid aspect of the hepatized and consolidated lung. Consolidation by various or microorganisms may be similar to atelectasis. They are quite similar. In many cases, you can see a bronchogram that may be moving or not, some kinds of little hyperechogenic spots, as in this case. Another thing you can see is when there's a process of necrosis in areas that are hyperechogenic and non-vascularized. And that is a thing you can spot in tuberculosis. That it's not specific, because you can see that too in other bacterial infections, but you can see that in tuberculosis too. And further thing you cannot see well in X-ray is fluid filled intraparenchymal cavities. As in this case, this is not a tuberculosis. This is a pneumatocyte and pneumatocyte with fluid, but not recognizable, of course, in X-ray. Of course, the second biggest use after the diagnosis is the treatment and the controls pre-drainage and post-drainage, as in this complex effusion. Normally, when we use ultrasound for the control, we tolerate about a remnant of 3 to 5 millimeters of thickness of the remaining fluid and thickening of the pleuras. But what about the lung itself? Well, the lung itself has been growing its use by point of care, by clinicians, etc., not only radiologists. There are in adults 12 zones of the lung in 6 sites, 6 zones per side, or in children more standardized to 3 to 4 zones per lung. There are many signs that sound funny, and you should know they exist to be able to apply them in case you don't perform usually personally the ultrasound. There's the bad sign that's only for you to know. This sign is only useful to identify between adjacent ribs the pleural line. This should be the form of the bat. You have to have imagination. This is another sign for normal lung, the classical A lines. The A lines are reflections of the ultrasound in the pleural line at equidistant spaces that show aerated lung or air in the field. More useful is the lung sliding for a normal lung, the lung sliding of the pleura against pleura, and what you call the ant path, this irregular pleural line. This is a normal appearance. It's very useful to identify present normal lung moving. Associated with that, you have the seashore sign. If you use the M mode, we don't usually use much of the M mode. The cardiologists use more in the M mode. But it's very practical. Along this line, you see all the things that are not moving. All the superficial planes here are represented against time as lines. All the things that are moving from the pleural line to the depth is irregular because they are moving. So this is the seashore sign. These lines would be the water, and this area would be the sand. That's the seashore. So just for you to know, very useful. The B lines, the classical B lines, are the perpendicular to the A lines, originating in the pleural line. They do not attenuate with depth. Don't confuse them with other spurial lines. And they are due to interstitial edema here, and maybe hemodynamic or inflammatory. They are due to subpleural interlobular septa thickening, and it's been studied that this correlates with thickening of deep septae too. And this has been called interstitial syndrome. It's very non-specific, that name, interstitial syndrome, but it has been determined they are more or less equivalent to the curly B lines. You can have those lines in a lung in a zone and not in another zone of the same lung. Here you have the A lines. In another part of the lung, you have some B lines here, and in another part of the same lung, you have confluent B lines. The thing is, it's not specific. Various pathologies can have that to a compromise of interstitial and alteration of alveolar capillary membrane, and many things, including pneumonia by various agents, can cause that. You can another sign the clinics have named is the shred sign between the consolidated lung and the rest of the lung, this irregular pattern. And another fancy name would be the tissue-like sign. That is how you see a consolidation. We just normally refer this as a consolidation, but you can also refer this as a tissue-like sign because it looks like tissue with some moving bubbles, hyperechogenic bubbles in the bronchi, in the air bronchogram. Complementary to what we already know from the pleural effusion, you can use the M mode you now use to look for the sinusoid sign. You have the moving lung and it goes away towards and away from the transducer, and then you have this sinusoid sign that signifies the lung is moving freely in that liquid, that fluid. You can also use ultrasound for complications. Complications as in pneumothorax, when you have no lung sliding, as you can see here. This is the A line, but it's not moving, no lung sliding. You can have, as in this case, this is the air bubble of pneumothorax with A lines, but it's not moving. This is a consolidated lung, and this is a pneumothorax bubble here. And if you use that M mode, you are very familiar with now. You can see only lines because nothing is moving here. This bubble of air is not in the lung; it's fixed there. So you have these horizontal lines. That's called the stratosphere line or the barcode line by the Americans. So after this, so now we're talking briefly about what do we do with ultrasound in thoracic tuberculosis specifically. Well, that has been and will continue to be discussed. There's a challenge, of course, because of the amount of children with tuberculosis and the lack of sensitivity of the microbiological confirmation. And the problem with the chest X-ray, as was mentioned, is the poor sensitivity for some mediastinal nodes, and CT, of course, high radiation. So we have an imaging gap with delayed diagnosis and increased morbidity. What takes the ultrasound to the table? Well, of course, classical advantages: no radiation, portable, no sedation, very superior for fluid identification and characterization. It's cost effective, of course, in low resource settings, very useful, and it can be multi-system. Of course, with this in the same setting, we can explore thorax and abdomen. We have these many beautiful windows in ultrasound, and for lung and pleura, we can use a linear probe for superficial structures, subpleural nodules, with a convex lower frequency transducer. You can see deeper consolidations, larger effusions. You can use microconvex transducer, which is practical because you use that for everything, including cardiac. And for the mediastinum, you can use the suprasternal approach, as Nasrin mentioned, a parasternal approach. Unfortunately, subcardial, hilar, and lower node stations are not accessible by ultrasound, only the higher lymph nodes. Well, this is a beautiful article by Dr. Sori, Kujajit, and Singh Sori et al. In Pediatric Radiology illustrate exactly that, with hyperextended neck, how you can explore the lymph nodes. In this case, this example shows a lymph node with a conserved fatty hilum, but in many cases it may be with a central necrosis, losing that fatty hilum, as in this conglomerate. And in case of, and this other example of the same article, this big conglomerate is irregular in heterogeneity. You can also have, besides necrosis, calcifications and peripheral calcifications. And but the very usual finding is some degree of consolidation in ultrasound, because 2/3 or more of cases have some degree of consolidation. So you look for that in ultrasound too, always. And you can find necrosis in cases as this one, areas of hypoechogenicity in the midst of the consolidation. You can also find thickened area bronchogram in some cases. In cases of big cavitations, as this beautiful case, you have the cavitation visible because it's subpleural. The deeper the cavitation is, unfortunately, the lesser sensitive the ultrasound is. In this case, you have this cavitation with thickened content area of consolidation, and here you have also the pathological. Then you have another example.
Apologies. The screen share is lagging behind. So what you're currently describing,
Excuse
we're
me?
not seeing the slide.
Excuse me?
The current slide that you're showing is not what you're describing. It looks like there's a lag, or the slides haven't actually progressed. So we currently
It's
on the
like
slide
a lag, a
science
delay.
pulmonary ultrasound, normal lung. So we're on the slide science in pulmonary ultrasound, normal lung. That's the slide we're on.
May I can share because I'm near the end now. I should I share again? Is there maybe a lag in internet or
Please, if
something?
you can, I think if you
Well,
can, yes. So go on to the slide that you're speaking, and then we can start with that, because I think it was a video. So that video continued to play, and the next slide didn't progress.
a video. Oh, but what you now are seeing the progress.
Yes, we are. Thank you.
Oh, the thing is, I don't want to make you lose to take a lot of time, but what were the last? I don't know why there was a lag in there. Did you see these slides? Because it's most of the presentation.
Yeah, I think you can start from here. Yeah. You know, we have already covered. Yeah, okay, that's fine.
Oh, I don't. Nasrin, can you speak to me, Nasrin? Because I'm not. I don't know if.
Yes. So currently, I've got you on the slide science in pulmonary ultrasound, pneumothorax. Now you science in pulmonary
Yeah.
ultrasound, pleural effusion.
Yes. Okay, but you see, I am moving forward now, or is it fixed again?
It's fixed again. It's fixed again. I think you'll have to go to the
Oh
next
my
slide.
God. Maybe I should change my internet connection because this is working perfectly for me, but I don't want you to get stuck here. I should
So we
because
on science
I
in
from what you told
ultrasound,
me, maybe
pleural
you didn't.
effusion.
Oh,
I
the thing
I
is,
think
no,
the
I mean,
video
you
is
missed
what
most of the.
I think the video is what's
No, but
actually playing.
it's no, but no, I think it's an internet thing because my it's working perfectly. I mean, I'm going forward with no issues here. It's not stuck or anything because so it's something in the communication of a Zoom link or my internet or I'm surprised because it's working
I
perfectly.
think you can. I think you can start your
Maybe if you
science in
want to go to the
pulmonary
next
ultrasound,
speaker,
pneumothorax. I think you can continue from here. Science in pulmonary ultrasound, pneumothorax. You can continue. We're seeing the
okay.
slide.
Sorry, but we uh okay, and now you see it's progressing, okay?
Yes, science in pulmonary ultrasound, pneumothorax.
Then the lung sliding, the stratosphere sign. Oh, I'm so sorry you didn't see um what I was saying. The let's progress to the to tuberculosis. You already heard me, but let's concentrate in some particular points so you don't waste your time in repeating everything. The thing is, I was mentioned in this beautiful article by Sori et al. With illustrating what you already mentioned, the approaches for the nodes, the mediastinal nodes, you have the suprastellar with hyperextended neck suprastellar approach, and you have, as in this case, where it has its fatty island preserved, but in many cases, if it's necrotic, it may not be preserved. It may be enlarged and with an altered structure. As in this case, it may be a conglomerate with central necrosis, and in some cases, it may be calcified. The thing is, we have in two-thirds or more of the cases, we have some degree of consolidation, and you can find necrosis in the midst of the consolidation. You can find cavitations, as in this case. Can you see the picture now? Cavitation.
Yes.
Oh, okay. Because I don't know if it was progressing. I was mentioned the article was by Sodi and collaborators regarding one other point where ultrasound can be complementing the X-ray, as in this case, a collapsed lung from bronchial stenosis, where you can see in ultrasound the collapsed lung in if you have a good window, the enlarged hilar nodes that may cause the extrinsic compression of that bronchi, in some cases also fluid in the bronchi. We have a couple of case examples. This is from the European Societies from Dr. Lorensky, and we have this 15-year-old with persistent fever and abdominal pain with this irregularity in the product that was almost missed. But we sometimes you don't have a big consolidation. You only have small subpleural consolidations and irregularity that may be due to the thickened pleura and also the presence of P lines due to interstitial edema. In this case, you would see this
Yung problema dito,
thickened.
sobrang lalaki ng truck.
Yes. Okay, that was that you can see the correlation here with the pleural thickening in the CT. You have this other more notorious example with non-conspicuous lymph nodes at all, but you have persistent fever with under antibiotic therapy and the pleural effusion. The pleural effusion was in this case loculated, complex with septi, and also with associated small atelectasis area with compressed vessels, high consolidation aspect of this area.
Hello.
Excuse me. One interesting thing some authors have done, that's an interesting case, but Munyan Gayu et al. Is a meta-analysis of series of patients that in all cases show a high sensitivity and specificity with the best performance for association of consolidation and lymphadenopathy that you can assess with point of care. And the nice thing of point of care ultrasound, it has a higher sensitivity in this meta-analysis that chest X-ray. I found that interesting. And there are other studies that show that in this work, there's a study in Guinea-Bissau showing the feasibility of point of care ultrasound in resource limited settings with point of care ultrasound done for tuberculosis only in primary health centers with handheld devices as a triage tool in context of severe malnutrition even by non-specialists. So there was a specialist trained 2 to 3 weeks only and reducing CT necessity. As an overall scheme to sum up the role of ultrasound, it would be here in a comparison table. Ultrasound would be good for consolidation, but mostly subpleural, and good for mediastinal nodes, but partially because it's mostly for stations 1 to 6. excellent for fluid, of course, bedside, portable, and we know, of course, the advantages of CT, but with the high radiation and limited availability, and of course, MRI is going to be talked about with, unfortunately, limited availabilities of ultrasound. Looks really nice. What is the for the future? What's the problem? There are no consensus protocols, heterogeneous definitions, what significant lymph nodes are, and there are multi-center studies are needed. There's not a validated scoring system. There's also a problem of the variability of the training of the persons doing this ultrasound for detecting the lymph nodes and looking at the lung. And the pediatric specific criteria are really needed. So those are some of the references. Well, thank you very much. I'm sorry you didn't get much of my talks in real time. Sorry, I don't know exactly what of the pictures you could look at. I'm open, of course, for discussion later.
Thank you so much. Perhaps we could share your presentation on a PDF format for all the delegates. Thank you.
Yeah.
So our next presenter is Dr. Sodi. Can you share your presentation?
Yeah, sure.
Just a brief background. Dr. Sodi is the Vice President of the Asiatic Society of Pediatric Radiology. He is also the Secretary of the World Federation of Pediatric Imaging. He's the President of the Indian Society of Pediatric Radiology. He has over 250 publications and 17 book chapters. And most importantly, is one of the leaders in MRI imaging of pediatric TB. So welcome, Dr. Sodi.
Thank you, Dr. Nasrin. Can you see my slide?
Yes, thank you.
All right, thank you. So I'm going to be speaking on MRI chest for tuberculosis in children. That was the mandate given to me. Okay, just to give you a brief perspective from where I am speaking from. So this is my institute, Postgraduate Institute of Medical Education and Research, which is in northern part of India, something around 150 miles upwards from New Delhi. So what is the role of imaging in thoracic tuberculosis? As Dr. Bernard Lea also alluded in his talk, so the role of imaging in thoracic tuberculosis is threefold. First, diagnosis. Second, looking at the response. And third is, of course, trying to pick up complications. So thoracic involvement in tuberculosis can be pulmonary, lymph nodal, pleural, or a combination of these. So why do you want to do lung MRI in the first place? This is because of the reason that this is now being increasingly used because it is a radiation-free alternative to chest CT, which definitely involves some degree of ionizing radiation, even though we have a low-dose CT protocols also coming up now. But MRI, since it does not involve any radiation, so it is by and large being increasingly being used up in areas where CT scan was used earlier. So in pediatric tuberculosis, what is the key for imaging finding? That is the lymph node. All right. It is good to see that MRI yields sensitivity, specificity, positive and negative predictive value of 100% for detection of mediastinal lymph nodes when they are more than 7 millimeters in size. These are from various studies now published in the literature now. MRI has also been successful in demonstrating perfect correlation with multi-detector CT scan in the detection of pulmonary consolidation, nodules more than 4 millimeters in size, cyst cavities, and effusions. Of course, when we started to look at and try to use lung MRI in chest, there were a lot of challenges involved, predominantly being the low tissue density, susceptible to differences between the tissue and air, leading to rapid signal drops, and tissue motion because of respiration and cardiac motions. So the basic lung MRI sequences which we can use in our practice are a single shot fast spin echo, a spoil gradient, and a balanced steady state free precision. If we have more gantry time, we can try to add a motion corrected technique or a volume interpolated GREs. So these are some of the sequences or the names given to different vendor specific sequences depending upon which particular vendor magnet you have in your institution. So these go by Haste or TrueFisp or Fiesta and Lava and so on, right? You can also optimize it so that you can get a faster scans. For example, in our institute, when we started doing lung MRI in nearly in 2010 or 11, it's been 15, 16 years now. So we optimize them so that we can use these MR sequences. These 4 MR sequences takes less than 2 minutes in a child, because in a child specifically time is of great essence, right? There are a lot of publications now coming up, and this is one of them where we worked on and advocated a practical protocol for lung MRI for common clinical indications. And depending upon whether we want to look at parenchyma, vessels, soft tissues, or airway disease, and of course the age of the child, the sequences types, of course, is going to change. This is a good article for imaging recommendations and algorithms for pediatric tuberculosis from the WFPI group and Nathan, Bernie, Savaz, Zaleha, Maria, and myself, in which has been advocated a role of MRI, especially for those children who do not require sedation, as I'm going to talk about it shortly. So children, remember, up to 5 years, they frequently cannot follow free breath hold instructions, and therefore you might have to do free breathing MRI techniques with them, with sedation or anesthesia. Now that can be quite tricky and of issues at time. But in children who are more than 5 or 6 years of age and can follow breathing instructions, they can undergo MRI without sedation with adequate preparation and training, and these form the bulk of the children now who can undergo MRI instead of a CT scan. We have also tried to compare lung MRI and compare them with X-ray and CT scan, specifically in children with thoracic tuberculosis, and we looked at various predefined parameters such as effusion, nodules, consolidation, cavitation, bronchiectasis, and lymph nodes. And you can see here, taking CT scan as the imaging gold standard, MR was quite comparable to CT scan for pickup of nodules, lymph nodes, cavitation, which are the hallmark of pulmonary tuberculosis. Let me take you through some of the images, some of the cases one. So this was a child with an equivocal chest X-ray, not sure whether lymph node is there or not. So we did a contrast enhanced CT scan and also an MR at the same time. And you can see this right hilar lymph node very nicely seen on MR, even without giving any contrast, right? Some of the other imaging features of tuberculosis can be picked up on lung MR include various degrees of cavitation, breakdowns, nodules, of course effusions and empyemas as well. And this is an example of tubercular empyema on MRI, which correlates very well to the CT scan. So all these entities or conditions where a surgeon wants a surgical roadmap of a cross-sectional imaging, we can advise or perhaps do an MRI in case of a CT scan. We have also published this subsequently. Even in children with tuberculosis with HIV, which is also a very important subgroup, MRI has been able to demonstrate a very high sensitivity and specificity for picking up of nodules more than 4 millimeters, effusion and lymphadenopathy in this HIV positive children. So this is a very specific indication. Children with TB and HIV, right, where MRI can also do wonders. And just to illustrate my point, you can see in the top you have left hand side the CT scan and the MR on the corresponding right hand side, and you can see this large lymph nodal mass on CT as well as which is very nicely demonstrated on the MR. Mediastinal nodes is something which is MR does pretty good actually, and if for all children more than 5 or 6 years of age who do not perhaps require sedation and the chest X-ray is equivocal, I think MRI can easily replace CT scan in this specific entity and specific age group, right? For example, you can see in this child with a large pretracheal lymph node, these are 3 different MR images on your screen and the corresponding CT scan. So MR quite nicely picks up this pretracheal lymph node. And in this particular child with tuberculosis, you can see in the topmost section contrast enhanced CT scan, you have multiple large conglomerate necrotic lymph nodes, which is quite pathognomic of tuberculosis. And also you can see this similar looking lymph nodes on MR, where you can see this T2 hyperintensity, which is indicative of liquefactive necrosis. So without giving contrast in MR, you can pick up these lymph nodes, which is a pretty important finding. Now, signal intensity in TB, remember, differs in different patients depending upon the stage of the disease, degree of evolution, and the site. High signal on T2 weighted images, especially in the lymph nodes, can be indicative of a central or liquefactive necrosis, right? While low T2 signal intensity of the necrotic lung parenchyma has also been described in children with thoracic TB in some papers. The future perspectives of MR include diffusion weighted imaging, where some studies have shown restricted diffusion in tuberculosis. UTE or ultra short TE imaging, I'm going to show you some of the examples just shortly. And of course, motion corrected rapid MR sequences, which can make our lives easier. Of course, MR does come with some limitations. The first and foremost is the low signal because of the resolution is lower now. You might miss up small calcified masses of nodules still on MR. In smaller children, as I alluded to earlier, sedation can be an issue. Free breathing you might have to do. And of course, some false negatives and artifacts, which always come with MRs and a higher field strength, right? Ultra short echo time imaging is one of the very promising tools coming up in MRI. So what happens in this is at a very low TE, at less than 100 microseconds, you can get MR imaging with parenchymal sensitivity equivalent to that of a CT scan, right? So the most common of these methods uses radial case space encoding, which has a short advantage of a short readouts, so that you have a very minimal T2 related signal decay and a good parenchymal signal strength. So this is how a UTE sequence looks like, and it almost looks like an CT scan or HRCT image, right? But this is a new UTE MR sequence which gives you a parenchymal resolution sensitivity quite comparable to that of a CT scan. Just to show you another example of this ultra short TE sequence, you see on the top is the UTE sequence, in which you can see the train bed appearance, bronchiectasis much better as compared to the conventional T2 and the T1 GE sequence which we use, right? Of course, at times you can make use of MR if required in specific entities. I'm not trying to advocate to do a functional imaging in all the entities, but sometimes you might require do a dynamic MR or a cine MR imaging, and lung ventilation and perfusion studies are also possible today to look at the functional aspect of the lungs in these patients. Just before I end, a quick word. From the World Federation of Pediatric Imaging, we have a website, and a lot of TB resources are available on the WFPI website. Just go to the website. We have a TB corner as well, and there are a lot of lectures and videos and teaching material available free of cost for you to browse through. So in summary, I would like to say that MRI for chest TB today is a technically feasible, radiation-free imaging modality. You can actually do a very rapid lung MRI in 2 to 3 minutes all. It doesn't take too much of a time as is normally believed. And it has a specific use in a selected group of patients, specifically for mediastinal lymph node detection and picking up complications where infrastructure and expertise is available. Thank you.
Thank you so much, Dr. Sarvi, for that excellent talk. I'm now going to introduce our next speaker, Dr. Saleh. If you can please upload your presentation.
Can you see my presentation?
Yes, well, we can. Go ahead.
So Dr. Saleh, yes, so Dr. Saleh is the Vice President of the African Society of Pediatric Imaging, AFSP, She is an associate professor of radiology in Addis Ababa in Ethiopia, and she specializes in pediatric neuroimaging. Thank you.
Thank you, Nasreen, and thank you everyone for the opportunity to speak today. I actually do both adult and peds neuroradiology. I have nothing to disclose relevant to this talk. So I'll just give a very brief introduction, as a lot has been said on the statistics of tuberculosis in pediatric patients. And we'll talk mainly on the CNS brain part of the CNS TB, focusing on the meningitis and tuberculoma. And I will leave the rest to Dr. Kilborn and give a short summary. So the statistics, updated statistics have already been mentioned, but I would just like to point out the global impact of tuberculosis, not just on the patients, but on the family as well as on society. And the age group that is commonly seen in terms of CNS TB and the severe form of extrapulmonary disease of CNS tuberculosis has an extremely high mortality. And the diagnosis is often delayed, partly because of the non-specific presentations of patients, making it very difficult to make the diagnosis in a timely manner. A brief pathophysiology. It starts off in the lung, which has been described beautifully by Dr. Nasreen, and then spreads through hematologic spread to the subpial or subependymal infective foci, and then spreads into the central nervous system. And the presentation differs according to the site that has been involved. I'll be mainly focusing on the meninges, as I've mentioned, and some of the features of brain parenchymal CNS TB infections. The spinal cord and the spine I will leave to the subsequent speakers. So this is case one. This is a patient that had presented, and you can see on the images that there is a meningeal enhancement, particularly involving the basal meninges. You can also see that there is dilatation of the lateral ventricles with adjacent hypodensity surrounding the lateral ventricles, suggestive of acute hydrocephalus. So this is a case of TB meningitis on CT scan. A companion case, you can see that there are additional findings in this particular patient, and the enhancement, as you can see on the post-contrast images, you have basal meningeal enhancement, but you also have other additional findings in this particular patient, which we will see later through the in the presentation. Another companion case, a 3-year-old, presented with seizure and right side body weakness. Again, you can see the diffuse meningeal enhancement, and you can also identify that there is enhancement involving the posterior fossa as well in the cerebellar hemisphere, as well as this thick coating enhancement along the brainstem, as well as the visualized part of the cervical spine. And you can see it's also coating the brain parenchyma, particularly the posterior fossa, which is well seen on the sagittal images. This patient also had concomitant other findings involving the brain parenchyma with this multiple different sized T2 hypointense lesions involving the bilateral hemispheres, which I will discuss later on. So to say a few things about TB meningitis, leptomeningeal enhancement is common. There are thick exudates involving the subarachnoid spaces, particularly the basal meninges, in the interpeduncular fossa, the suprasellar cisterns as well. You should also keep in mind that there are multiple differential diagnoses to consider in patients with a meningeal enhancement, particularly pyogenic infections, sarcoidosis, or neoplastic conditions in these patients. You can also have pachymeningeal enhancement. The bottom case is the one that I've shown you, and the top case I will show you later on, but you can see this thick enhancement involving the meninges. You should also look for complications, particularly hydrocephalus, which we've seen in the patients that we have seen so far. Other complications such as infarction, particularly in this patient, you can see on the diffusion weighted images that there is diffusion restriction, which was a complication of basal meningeal enhancing meningitis, which was proven to be tuberculosis. You should also look out and see if there are any cranial nerve neuropathies in patients with TB meningitis. Images should also be correlated with lab investigations, CSF analysis, particularly in these patients. One important thing to note is that imaging can be normal in patients with TB meningitis, and this should also be the absence of any enhancing lesion does not mean that the patient does not have TB meningitis. So case 2 is a 4-year-old male with headache and vomiting. Perilesional edema. You can see that there's no blooming on the middle image, the GRE sequences, and post-contrast shows conglomerates of rim enhancement in this patient. Patient had follow-up images following anti-TB initiation. You can see there's some improvement of the enhancement pattern, but 11 months post-treatment, you can see that there's significant improvement in the enhancement and the perilesional edema in this patient showing significant improvement. Companion case, similar involvement involving areas, but now you can see that there's also involvement of the suprasellar brain parenchyma with significant perilesional edema. On the sagittal images, you can see that it looks like there is swelling involving the pons in this particular patient. Post-contrast images shows this a fluffy kind of conglomerates of rim enhancement involving both the supra and the infratentorial brain parenchyma. Notice that the diffusion-weighted images does not show any restriction in this particular patient. Case 3, this was an older case of a 2-year-old boy with lethargy and vomiting. I like to show this case because of the T2 dark signal intensity is quite staggeringly it's not easy to miss, and you can see that there are multiple lesions involving the posterior fossa with perilesional edema, and you can see that there's no restriction in this case with multiple thin rim enhancing lesions involving both the supra and the infratentorial brain parenchyma. Companion case of a 13-year-old with difficulty of keeping her balance of 4 months duration. Similar signal intensities. However, the signal intensity on post-contrast images show this quite thick enhancement, peripheral based with some areas of internal enhancement of these cases. So posterior fossa lesions in the pediatric population, the first thing that we usually think about are brainstem gliomas, pielocystic astrocytoma, medulloblastoma, ependymoma, and in adults, metastasis and hemangioma are the things that are considered. But in TB endemic areas and now with global migration of people, you should also put TB as a differential diagnosis, particularly if they have the T2 dark signal intensity. I always show this case if I ever give a TB presentation because it was one of the cases that we missed in our institution of a 10-year-old male with headache and left side body weakness. And you can see that this patient had this large complex mass with areas of calcification on the CT with mass effect, dilatation of the lateral ventricles with signs of acute hydrocephalus. MRI, you can see the imaging findings with this strange enhancement pattern, and we thought primarily that this might be a supratentorial ependymoma. Patient was operated with that possible first diagnosis, although TB was put lower down in the differential diagnosis, and patient post-op was diagnosed with tuberculoma. Patient is alive and well, although he remains blind in his own follow-up for seizure. But you can see that TB can have such a diverse enhancement pattern and presentation in the brain parenchyma. Similar findings here of a patient with proven TB cases involving both the supra and the infratentorial parenchyma. One important thing is that this patient had a chest X-ray which was done 10 days apart, and you can see that this patient also had miliary tuberculosis. So the most important thing to consider in patients with CNS TB is also to check the chest, as most of them will have TB infection involving the chest as well. Case 6 is a 14-year-old girl with visual blurring of 1 month duration. You can see these T2 hypointense lesions with perilesional edema. At this point, I think you have realized that I have mentioned T2 hypointense several times, and there's a reason behind it. Post-contrast images show these multiple rim-enhancing lesions throughout the brain parenchyma. The patient, 8 months post-treatment, you can see that on follow-up images, there is a change in the enhancement pattern of this particular patient, even though the patient has been on treatment for 8 months. As a comparison, the yellow ones are the pre-treatment images. The ones in blue are the post-treatment images. And you can see that there is improvement in the size of the lesion, particularly involving the suprasellar area. But you can see now that it looks more of a thick pachymeningeal enhancement is also seen. So this is one of the cases that I showed you for the pachymeningeal enhancement on the meningeal part of this presentation. Another thing is that cases can be quite peripheral. The enhancement pattern might look like an extraaxial mass. In some cases where we have had discussions with our neurosurgeons that this could potentially be an extraaxial mass, although this patient was reported as a case of tuberculoma, the patient was proven to be TB. A companion case just to show you that sometimes you can have dural enhancement adjacent to a peripherally based lesion. That does not mean you should change your mind based on the signal intensity of the lesions that you see. A diagnosis of TB was made for this patient preoperatively, but neurosurgeons decided to operate, and a diagnosis of meningioma post on pathology was made. But this was, they were considering a diagnosis of meningioma. However, the diagnosis was tuberculosis. This is another interesting case of a 6-year-old who presented for our MDT, and you can see these rim-enhancing lesions on the images, and you can see how dark the T2 signal intensity is on MRI. Post-contrast images, you have this meningeal enhancement as well as multiple rim-enhancing lesions. This patient was shunted, but he later on developed fever and was intubated and was in the ICU. 1 month later, you can see that there is this patchy area of hypodensity in this particular case. We were considering the possibility of a new development of a stroke, but you can also see that there were new developments of chest findings in this patient. Could it be post-vasculitis changes? We didn't know, but the patient was admitted to ICU. So tuberculoma, the MRI appearance is variable depending on the stage of maturation. It can be non-caseating, it can be caseating with solid granuloma or caseating with central liquefaction. And this is a nice flow chart that I made just to show you the importance of looking at the T2 hypointense signal intensity of tuberculomas with a solid caseating type. You should also think about other differential diagnosis, of course, of causes of T2 hypointensity on imaging, such as calcification or hemorrhage. Calcified granulomas can occur post-treatment as well. The role of advanced imaging, it depends where you are and if there's a need for it. There are literature out there that have used MR spectroscopy as a possible additional imaging modality to implement to differentiate between tumors and TB. But I think it's also very important to know your epidemiology. And if you come from a TB endemic area, you should really consider the diagnosis of tuberculosis in your cases. So all of these are cases that I've shown you today, and you can see that there are variable degrees of T2 hypointensity, and variable types of enhancement patterns, but all of these cases were TB. So the top ones are the T2 weighted images, and the bottom row shows you the enhancement patterns. So these are all cases that I've shown you today. Case 9, just to show you that this particular patient had diffusion restriction, and this was one of the cases that I initially showed you, the one that had meningeal enhancement, but you should also notice that if you had seen the case that there is also ventricular wall enhancement, and this patient also had ventriculitis, and this was a case of TB abscess in this particular case. This is a very interesting case, a 16-year-old female who presented with left frontal head swelling of 6 months duration, which was associated with a mild global type of headache. And you can see that there is a lytic destructive lesion involving the frontal bone with multi-compartment involvement with soft tissue swelling. And you can see on the post-contrast images and on the MRI that it is involving the scalp, the cranial vault, as well as intracranial extraaxial involvement of this particular patient. Of course, in pediatric populations, you should have other differential diagnoses as a consideration, such as Ewing sarcoma, Langerhans histiocytosis, osteosarcoma, or metastasis. This was diagnosed to be tuberculosis, and this case was published by our neurosurgery colleagues, and you can read if you want to know more about this case report that was presented. Case 11 is a 3-year-old, last few slides, just to show you that you should also look elsewhere, not just the brain parenchyma. If you have noticed that this had an intraocular enhancing lesion, Patient was on anti-TB. 3 months later, you can see that there is improvement in the size and in the enhancement pattern, but you can also see now that the lesion in the right temporal fossa and temporal lobe has calcified with reduced globe size as well as calcification of the enhancing mass in the globe. So these are the changes that have been described. This is an adult case with similar findings, multiple rim-enhancing lesions throughout the brain, and this patient also had this focal T2 hypointense lesion involving the globe with enhancement pattern. Patient also had the lung findings, and patient was on anti-TB, and follow-up images were not available for the brain. So ocular TB, tuberculosis involving the orbit, is quite rare, even in tuberculosis endemic areas. There are some publications out there, but usually our ophthalmology colleagues report that their commonest presentation is uveitis and chorioretinitis, and you can read more about this. Just to highlight, you've seen the enhancing patterns, but also always make sure that you look at the visible parts of the neck, just to make sure that you haven't missed any lymphadenopathy that can help you make the diagnosis in these cases. So don't forget to look at the neck. This is another case of a female teenager with headache, and you can see the enhancement patterns. But 6 weeks after anti-TB, you can see that there is worsening of the perilesional edema as well as of the enhancement pattern of this case. And you can see the pre and the post-treatment cases where you can see worsening after initiation of TB. I'm not going to discuss too much about iris because Dr. Nasreen has already mentioned it, but causes of worsening once treatment has started can be paradoxical worsening. It could be treatment failure. It could be drug-resistant tuberculosis, or it could be the wrong diagnosis. But it doesn't mean if you shouldn't feel like you should be pressurized into changing your diagnosis. If you have worsening, you should consider multiple findings, look at the ESR, and the tests and chest x-ray to make sure that you're on the right track. So what is the take-home message? CNS tuberculosis is a diagnostic dilemma in most cases. Look at the T2 signal intensity. It can help you make the diagnosis. Look at for unusual findings such as ocular involvement of the scalp, in the calvarium. Treatment, don't discontinue treatment if there's initial worsening of symptoms. It doesn't mean that you have the wrong diagnosis. Paradoxical worsening is not equivalent to wrong diagnosis. And with the global movement of people around the world, it's no longer a disease in endemic areas only, but there should be a high alert in areas where TB is not endemic. So thank you very much, and this is my city. Thank you for the opportunity to present.
Thank you so much for that comprehensive lecture. Can I ask Dr. Kilborn to load her presentation? Dr. Tracy Kilborn is a pediatric radiologist at Cape Radiology. She is an honorary consultant at Tygerberg Hospital in Cape Town. She has published multiple papers and been involved in multiple research projects in pediatric TB in South Africa and internationally. Thank you.
Thanks, Nasreen, and thank you so much for the invitation, WFPI. So, sorry, I'm just trying to get my slides to advance now. So I don't have any disclosures. In my presentation this afternoon, I'm going to discuss the manifestations of TB in the spine, the spinal column, the cord, the dural, and the extradural space. So just we've heard a lot about pathophysiology, and it's similar within the spine, but has some unique differences. We can have TB spine from hematogenic spread, latent reactivation, or spread from adjacent disease. Organisms lodge in low flow vessels that are adjacent to the subchondral plate, which you can see here. They're often the anterior superior and anterior inferior end plates of the vertebral body. We do know that we have blood vessels that also go into the cartilaginous portion of the disc, and these promote movement of organisms into the disc. The difference between TB and bacterial enzymes is that we know in children bacterial like staphylococcal spondylodiscitis is very, very common, and that's because of the enzymes that those bacteria have. The difference with TB is that it lacks the proteolytic enzymes, so we don't have that initial early disc involvement. Obviously, when we see patients, they're frequently quite advanced in their disease, and we will see discs, but you can usually, when you look, you can see remnants of discs. So it's important to remember it's predominantly a spondylitic type illness affecting the body and then affecting the disc a little bit later. This has already been comprehensively covered by colleagues. It's, again, TB spondylitis is often insidious and the symptoms are non-specific: back pain, limp, a mass. And when we're looking for other evidence of TB, the difficulty with TB spondylitis is that we only ever see active intrathoracic TB in 50%. Now, that's literature taken from chest x-rays, and as we've also heard this afternoon, with the updated imaging with MRI, that will probably become a different percentage. So particularly in resource-limited settings, x-rays are often the common first-line investigation, but they're pretty insensitive because you need about 50% of bone loss to visualize, and this can take 2 to 6 months from infection. We know it's poor visualization of, for example, the craniovertebral junction and the lumbosacral junction and the posterior elements. Ultrasound is often used as to look at for ancillary causes of foci of TB, or to guide intervention, but MRI remains the gold standard. And we need to remember always to image the whole spine to see non-contiguous disease. In areas where there's no CT, no MRI, CT may be used, but this is really rarely used and potentially only for pre-surgical or pre-drainage type imaging. Again, as already mentioned, we can suggest it by imaging, but often the treatment requires microbiological identification. And certainly in our setting, the orthopedic surgeons have become much more vigilant about trying to get samples just because of the high incidence of multi-drug resistant TB. So we'll start off with tuberculous spondylodiscitis. And this is a case of a 13-year-old with lower back pain. This was the initial X-ray presentation, and it was regarded at that point to be normal. There was nothing to find on clinical examination, and the patient was discharged to come back to the orthopedic clinic. When the patient came back, they had leg symptoms, and so proceeded to an MRI. And if you look in hindsight, you can see that the S1 vertebral body is sclerotic. But by the time the patient had the MRI scan, there was destruction of the S1 vertebral body. You can see extrusion of soft tissue posteriorly into the canal, and the classic anterior ligamentous, anterior longitudinal ligament elevation with the paravertebral collection. This patient presented with a gibbous deformity and with paraplegia. The plain film doesn't really show us the true extent of the disease, but we can see in the MRI that, in fact, there are 2 vertebral bodies involved in this process. And how we do that is by counting the spinous processes and trying to match them to the vertebral bodies. It's helpful just because when there's a large gibbous with a soft tissue component, you may not necessarily be able to see that. I'll come to this in a bit, but the astute of those of you will realize that there's something that looks like a bit of disc here and something that looks like a bit of disc there. So that may also give you a hint as to the number of vertebral bodies that have collapsed. 6-year-old with torticollis. Again, we know with these young children, plain films can be difficult. You can see, looking at the earrings, which probably should have been removed, that the patient's head is tilted and rotated. We've got soft tissue swelling. And yes, in hindsight, indistinct appearance of the tip of the dens. She went on to have an MRI, and you can see the extent of the disease. So we've got, on this post-contrast T1, destruction of the tip of the dens and a large enhancing collection surrounding the C1, C2 articulation. So in TB, 4 patterns of infection have been described. This is not, it doesn't really affect in terms of what you see, but it gives a good idea of how the disease progresses. The anterior pattern of infection begins in the anterior superior and anterior inferior vertebral bodies, as we already described with the hematogenic spread, causing wedging, and then the soft tissue or fluid extends under the anterior longitudinal ligament to involve other levels. In the central pattern of infection, it begins in the middle of the body, and you get a planar type picture. And the collection often goes posteriorly into the canal. Now, remember, obviously, in children, as Amal was saying, we've always got differential diagnoses. And in this, we would have to consider Langerhans cell histiocytosis, malignancy, as a different cause for our findings if we didn't have any other ancillary evidence of TB. The paradiscal arises from the disc. You'll see this is similar to this is the case that I showed you previously. And then the soft tissue collection extrudes anteriorly and posteriorly. And then the appendiceal or posterior involvement isolated to the posterior elements is very rare. And that's why we use the spinous process to count the levels of infection, because we very rarely see this pattern. Don't forget that with TB, I've already alluded to it, we often have associated paravertebral and soft tissue collections. The collections may be much larger than the degree of bone destruction. In this case, you can see that there's a single vertebral body which has maintained both its height and shape, with normal discs on either side within the lower thoracic spine. And we've got early involvement of the superior end plate of this lumbar vertebra. Yet we have an enormous collection in the psoas, and it was protruding out onto the patient's skin. This patient presented with a lump in the groin with absolutely no back pain or any other symptoms. And you can see the lump in the groin was in fact continuation of this large psoas collection that was arising from the multiple vertebral bodies involved in the spondylitic process. Again, these discs, although they've lost signal, are still visible despite the large collection. So as I already alluded to, discs are affected later in the process, but they can look like anything. So in this example, you can see that the discs have been subsumed or consumed within the anterior collection, and the discs have maintained both their shape and their signal. In this example, the disc has reduced height, but it still has some T2 hyperintensity, although anteriorly it's T2 hypointense, and the collection has gone anteriorly and posteriorly. And then this patient with a gibbous and kyphosis, you can see that despite the fact that we've got vertebral body collapse and one vertebral body completely gone here, we can still find discs incorporated within that inflammatory process. So what about these patients that present with gibbous and paraplegia? It's not an uncommon cause of paraplegia in children. It's one of the commonest causes, certainly in endemic areas, but it can become so obviously in areas who have not seen this before. And the reason for that is, as we already have discussed, that TB, certainly TB of the bone or of the spine, it's a slowly progressive condition. The spinal canal allows quite a lot of accommodation, and because it's slowly progressive, the symptoms only occur late. So as opposed to an acute thing like trauma or an acute bacterial infection, where you would get a much quicker presentation, this would present that much later. And you can see that by looking at the vertebral body collapse, the anterior and posterior collections. But again, you can still see the spinous process. Now, because of that slow progression and accommodation, we can't correlate really between what it looks like on the MRI and the neurology. You can have patients who look like this that are still walking, and patients who look a little bit less affected who are paraplegic. It's a worse prognosis with cord signal change, and also obviously with the gibbous if you have involvement of the anterior spinal artery. The other thing that this example eloquently demonstrates is the vertebraplanar appearance of the lumbar spine vertebral body with some thecal sac effacement, and it abuts the proximal chorda equina, and then two other vertebral bodies lower down that are of increased signal and also affected by TB. This patient did very well on treatment and actually completely regained use of limbs. This patient, however, remained paraplegic. And in this patient, which I showed you earlier with the discs, you can see that there's increased cord signal in the cord that's draped over the gibbous. Again, if you look more distally, you can see multi-level disease. And that happens in 20%, and that's why we image the whole spinal cord. Contrast, well, contrast enhancement depends on the pattern of destruction. It may be restricted to the end plate, as you can see here. There's the end plate involved. It can be the whole vertebral body, and it would obviously then also involve the associated vertebral collection. Depending on the amount of caseous necrosis, which Amal was talking about, or residual gummatous necrosis, it can look solid, as in this case, can almost look more like a mass, or it can be peripherally rim enhancing, and in this case, extending into the canal and compressing the chordae equina. We've alluded to this already, and we included into our protocol, which I've attached on the side, a coronal T2 in every patient that we imaged for TB spondylitis. This showed us in multiple patients evidence of T2 hypointense tissue, for example, here in the nodes, here in the lung, here in the spine, and here again, mediastinal lymph nodes. And just was, for very little time, gave additional information that the surgeons or clinicians could use if they wanted to look for other places to biopsy, particularly if there was treatment failure or treatment wasn't working and they were concerned about drug-resistant TB. Differential, this is a patient who had aspergillus, so don't forget it can look identical, and this was a patient with severe combined immunodeficiency. So just going on to the tuberculoma, abscess, radiculomyelitis, and epidural abscess, they're usually seen in the setting of TBM. So these will be hematogenous spread, and the patient will have presented with TBM. We found in our series that 70% of patients with TB meningitis had arachnoiditis or radiculomyelitis, so enhancement of the cord and enhancement of the roots. We can see it in TB spondylitis, but rarely and usually just limited to the area of involvement. Similar to what you see in the brain, the tuberculomas depend on the amount of necrosis or caseous necrosis, and this is a T2 hypointense lesion that's got peripheral enhancement, where this is sort of more intermediate, again with peripheral enhancement. So much like tuberculomas of the brain, they're going to look similar in the cord. And again, this patient was a patient with tuberculous meningitis, but what wasn't fitting really were the leg signs. This is, again, a patient with TB meningitis in whom there were multiple failed lumbar punctures and also severe neuropathic pain. And you can see this thickening and enhancement of the dura, a large intradural plaque, as well as the coexistent radiculitis and enhancement of the cord. So it's important also with patients with TBM, we started always doing a contrast enhanced spine at the same time, because sometimes it gave us answers to neurology and also to failed lumbar punctures that the clinicians couldn't understand. This was an unfortunate patient with TBM who had multiple lesions within his cord. Some were durally based, as you can see here. This one here is peripherally enhancing, but you can see there's some height signal on T2 and some intermediate signal on T2, and then other lesions that looked like they were more solid. So again, tuberculoma versus TB abscess, it's often quite difficult to tell on imaging because it depends on the amount of necrosis. Finally, epidural abscesses are more common in adults. They usually present with severe back pain and fever and coexist again with TB meningitis. They can occur with TB spondylitis, but it's quite rare, and you can see similar to that intradural plaque, but this has also got an epidural component. And again, if you increase your field of view, you can see the multiple enhancing lymph nodes within the mediastinum, again indicative of TB. So don't forget, in terms of the spine, when you're looking and you're wondering, am I dealing with bacteria or not? If it looks like it's predominantly body-based disease, multiple bodies at multiple levels, consider TB, scan the whole spine. You can usually find the discs. They can be of any signal. So a normal disc doesn't exclude it, and an abnormal disc shouldn't make you think of something else. Look for TB elsewhere to suggest diagnosis and guide additional biopsy sites. It's not a big time difference to add another sequence. And then if you do a purely spinal scan because of features of arachnoiditis or tubercular myelitis or spinal cord issues, consider that it may be TB meningitis and do the brain. So thank you for your attention.
Thank you so much, Dr. Kilborn. That was an excellent and comprehensive lecture. Can I ask Dr. Brown to load her presentation? In the interest of time, we're going to continue with the presentations and we leave questions to the end. Thank you. However, I do have on the live chats a lot of positive feedback to all the speakers. So thank you. So the next presenter is Dr. Brown.
Hi, Nasrin.
Good. Hi. She is the chair of the Outreach Committee of the European Society of Pediatric Radiology. She is the president of the British Society of Pediatric Radiology. She's a senior consultant at the University of Bristol. She's also the former president of the World Federation of Pediatric Imaging. She's actively involved in projects in Africa, Asia, and Europe. Welcome, Dr. Brown. I think you just need to put it on a slide mode. Thank you.
Yeah, I'm just doing it now. Sorry. Yeah, can you see my screen now?
Excellent, thank you.
Oh, brilliant. So let me make it a little bit smaller and we will go. So thank you very much for the invitation. And following our today's topic, I will be talking about the abdominal tuberculosis and imaging in children. As we all know, and previous presenter said, TB is a global health problem. Also, not only in the endemic countries, but also in all the countries in the world. Even in the developed countries, when we have all TB vaccination, we start thinking about the TB as a real possibility and a real diagnosis. But many countries, for example, UK, because we nearly eradicated TB in the previous 20 years, we stopped giving the vaccination in children. And we see it in our country, in our hospital, that TB is coming back. So about the abdominal TB. It accounts for 6 most frequent extrapulmonary sites. And the importance of this kind of TB is that it's related with and is associated with the very high mortality and morbidity due to the very non-specific clinical symptoms. And because the patients are presenting to the doctors and diagnosing at the very late stages. Also, we see the rapid progression of disease and severe complications. Difficulties is that only 15% of the children will have concurrent pulmonary TB, and the lesions and the pathological process can develop more than 10 years after the initial infection. So what are the clinical symptoms of abdominal TB? They are very, very non-specific. These children will present with the abdominal pain, fever, and weight loss. So very non-specific presentation. Triad of the symptoms that I just mentioned before occur in about 54% of the patients. So only half of our group will have the typical symptoms. But presence of these symptoms should always raise a high suspicion of the TB, especially in the endemic areas. So what's the pathogenesis in the abdomen? The most commonly, the children will be infected by the ingestion of the milk, which is infected with the Mycobacterium bacteria, or sputum of the patients with the active pulmonary TB. Then we could have a hematogenous spread, and a hematogenous spread again may occur years before the onset of the clinical symptoms, or we can have a direct spread from infected adjacent foci, as Tracy mentioned, psoas abscess, tuberculous spondylitis. It could be from the pelvis or from the infected lymph nodes. So abdominal TB is a very wide, has a very wide spectrum. We could think about the tuberculous lymphadenopathy, about the peritoneal disease, the disease which will affect the gastrointestinal system, or could affect the solid abdominal organs. We need to remember that the multiple intra-abdominal cells are seen in about 50% of the patients. So if we see one site infected, we need to examine our patients and look for more places. Combination of lymphadenopathy and gastrointestinal involvement is the most common, and lymphadenopathy is most common site of the single site involvement. So let's start from the lymphadenopathy. As I mentioned, is the most common manifestation of abdominal TB, often caused by ingestion of the infected food and milk, and we have enlargement of the lymph nodes. And this is a very classical presentation or location of the lymph nodes, mainly in the mesentery and omentum, and also within the epigastrium, so at the porta hepatis, along the celiac axis, and around the pancreas. So when we think about the lymphadenopathy in children, lymphadenopathy is present in so many different conditions. So we need to be sure that when we see the lymph nodes, this is when we need to think about the lymphadenopathy. But what is the characteristic features of these lymph nodes that will make us think about the TB, not other inflammatory, infective, or malignant conditions? So usually in TB disease, the lymph nodes, the multiple lymph nodes will be seen in the clusters, and you can see it here in the epigastrium or extending along the vessels. They will have a cystic necrosis and a peripheral enhancement, and also very often, especially at the later stages, will have a calcifications. So let's look through the different characteristic of the lymph nodes. So they will have a different allocation pattern. So we could see the increased number of the normal size lymph nodes everywhere in the omentum and in the mesentery. We could have scattered, mildly enlarged lymph nodes, or, as we said, large conglomerate nodal masses, as you can see here on the mid image, which is the most characteristic. Let's look at the characteristic nodal appearance. We all know that bacteria causing a necrosis and a cystic appearance of the lymph nodes with the central liquidation of the lymphotic tissue. And this is very often in the lymph nodes, we will have a cystic appearance, as you can see here on the CT, with central necrosis. About the nodal enhancement pattern, again, because we will have a lymphatic tissue in the periphery of the lymph nodes, which has increased inflammatory response and inflammatory reaction, we will have this characteristic peripheral enhancement that you can see it here on the CT. But we also will have a very highly vascular inflammatory reaction in all of the surrounding soft tissue and in the perinodal areas, that you can see it as an example of both CTs and MRIs on this slide. So as I say, abdominal lymphadenopathy, it's not always TB. So how can we make the differentiation between the TB infection and the infection or the changes from the other GI tract pathology? So what we need to think is about the location of the lymph nodes. In TB, as I mentioned, they will be most common, located in the mesentery, omentum, and epigastrum, and very often they are seen in the clusters and of enlarged and very heterogeneous lymph nodes. If we have any GI tract pathology, the lymph nodes will be smaller in size, secondary to appendicitis or other abnormalities in the pelvis. They will be seen in the right iliac fossa, mesentery, and very often along the loops of the small and large bowel. So often they will be seen more in the periphery of the mesentery than centrally as in TB. Also, in TB, you will have the infection with often necrotic centers that you can see it here on the examples of the ultrasound. With the other GI tract pathology, we will see the reactive and inflammatory features of the lymph nodes. So they will stop being oval in shape, they will be more round, they will be very heterogeneous in echogenicity with loss of the normal physiological and fatty hyla, and they will also have very often the changes in the surrounding mesentery. So ultrasound is a perfect tool in differentiation between the different kinds of the lymphadenopathy that we can see it in children. Second most common presentation of the abdominal TB is the peritoneal disease. This is where the disease is progressing. And we can have different types of the disease. We may see in our patient wet ascites, dry ascites, or fixed fibrotic type of the changes. With the wet ascites, we will have, as you can see here on this example, large amount of free or loculated fluid within the abdomen and pelvis. And the difference is that this ascites will have a much higher density due to increased protein level than the normal ascites due to infection or due to malignancy. So always put the and measure the Hansfield unit. We will also have prominent peritoneal enhancement, as you can see here in this patient, along the anterior and lateral wall of the abdomen. Then we can have a dry ascites, which is the fibrous response of the peritoneum into the infection. And in this situation, it will produce the nodules within the peritoneum or diffuse fibrotic changes and formations of the adhesions. And very often when you see the changes within the peritoneum, if you see the dry ascites, look at the presentation of the small bowel. It will be in the large bowel. It will be very important to look at the lumen of the bowel, if it's any thickening, or especially the orientation of the bowel. Do we have any developing adhesions, as you can see here, special angulation, or narrowing of the bowel loop that you can see it here. The wall of the bowel is not affected here, but the narrowing is caused by all of the peritoneal response, which is kind of enclosing and causing narrowing of the gastric lumen. Then we have a fixed fibrotic type of the peritoneal disease, which disease the omentum and the affects omentum and the mesentery. And this is mainly the type which extends into the bowel serosa and causes typical appearance of the matted bowel loops. And very often we can see the omental masses in this kind of the peritoneal disease. So again, diagnosing of peritoneal disease, we can use all of the imaging modalities that we have available. And very often, as we examine the children, we don't want to use CT due to radiation protection. We will see this very abnormal omentum and the peritoneum with the ultrasound. As you can see here, this very, very heterogeneous and a large mass with enlarged and necrotizing lymph nodes through the abnormality. The same appearance, you will have it on the MRI in this patient. You can see very diffuse peritoneal disease in the patient with very diffuse and very vivid enhancement with intravenous contrast. This is one of the other features that it will differentiate it between the TB and carcinomatosis of the peritoneum. And of course, we will see abnormality of the peritoneum on the CT, as you can see it in this patient. As I mentioned, we don't want to do CT very often in children, but we need to remember that these children often present in the emergency conditions with the acute abdomen, distended, painful abdomen with guarding. So CT is often one of the most available imaging modalities in emergency conditions. So how can we differentiate the peritoneal disease? Is it the TB infection, or is it secondary to diffuse cancer and metastatic disease? As I mentioned before, with TB peritonitis, especially with the wet ascites, we will have a high attenuation of ascites due to the high protein level. Then we will have diffusely thickened peritoneum, but which is usually smooth and irregular. We have a vivid enhancement with contrast in nearly 100% of the patient, but we can have a focal fibrosis and tethering of the mesentery, causing obstruction of the loops of the bowel and formation of the stellate lesion within the peritoneum. When we think about the malignancy, the ascites will have much lower attenuation in comparison to the TB ascites. We will have a very irregular peritoneal thickening, and we will have multiple nodules. And very often nodules will be in this characteristic distribution, as you can see here, the apple core in the anterior aspect of the abdomen, could be laterally or near the spleen, superiorly near the spleen and the liver. Multiple nodules could be scattered, especially near the affected organ, and we have a very different enhancement pattern in this patient. So another aspect or another organ in the abdomen that can be affected is the ileocecal TB. So is the most common form of infection of the gastrointestinal tract, and it will and is seen in about 90% of the cases of the patients with the infection of the GI tract. Why? Because we have a presence of lymphoid tissue, very prominent in the cecum and the ileocecal valve, and the relative stasis of the blood flow in this area. So clinical symptoms, again, are very non-specific. Is the diarrhea, is the fever and the night sweats, abdominal pain and distension, anorexia and weight loss. This is a very classical presentation for any abnormality related to the small and large bowel, as other kind of infection, or often in the Crohn's disease. So if we think about the gastrointestinal TB, we again have different forms here. We have the ulcerative form, which is most frequent. And then we have multiple small ulcers between 3 and 6 millimeters in diameter with very irregular margin that you can see here on the barium study, and often the orientation along the submucosal lymphatic structures. So this is the features that differentiate the ulcerative form of TB from the ulcerative form of the Crohn's disease or ulcerative colitis. Then we have a hypotrophic type with the extensive inflammatory response with the multinodular mucosal pattern and mimicking. Very often this could mimic neoplastic process. Or we can have a type which is mixed with the ulcerated and hypertrophic pattern, and very often we can see the combination of both with a cobblestone appearance, as you can see here on this CT. And again, very extensive changes here within the cecum with extension into the surrounding mesentery, which really mimic neoplastic process. And again, infection with the TB, as the previous presenter said, it's not static. It is developing. So when we think and examine our GI tract, we need to think, is it the early disease or the advanced disease? Because the presentation and clinical features and the diagnostic features will be completely different. In the early disease, we will have a spasm and hypermotility and edema of the ileocecal valve. We will have an opening of the itorsecond valve with narrowing of the terminal ileum that you can see here on the MRI, and we can have a diffuse small ulceration with the linear or stellate composition. We will have a fold thickening and irregularity, and we can have a skip lesion. In advanced disease, when the inflammation and fibrosis is progressing, we will have asymmetric annual stenosis and obstruction. We have a shortening and retraction of the pouch formation. Very often we will have this a very thick but open ileocecal valve, and we will have a retraction of the cecum out superiorly from the right iliac fossa into the abdomen. We will also have often ascites, lymphadenopathy, and the omental cake as other multifocal places in the TB infection in the abdomen. And again, not every ileocecal inflammation is secondary to the TB. We need to think about the amebiasis, about the lymphoma, about Crohn's disease or primary cecal malignancy and sarcoidosis. TB may extend also to the appendix and cause an acute or chronic appendicitis. Other parts of the GI tract that can be affected are esophagus, stomach, duodenum, and colon, but there are less common. As I mentioned, ileocecal region is affected in about 90% of the cases. And how do we look and how we diagnose and examine this part of the GI tract? Traditionally, fluoroscopy and contrast study was performed, and in many places we are still doing it. It's difficult when the child will present in the acute phase, because if we worry about the perforation, the performing of the contrast study is not in the best interest. But if we do the fluoroscopy on contrast study, depends on the stage of the disease. You can see here a narrowing of the bowel lumen with a multiple small and bigger ulceration and a fistula which is forming here. In more advanced disease, you will see here the narrowing and stricture of the bowel with very small cecum and displacement of the cecum superiorly from the right iliac fossa. Ultrasound is a perfect examination for examining of the small bowel, especially terminal ileum, and you can see here multiple examples of thickening of the terminal ileum, thickening and abnormality with asymmetric wall thickening here in the cecum, and also additional information of enlarged lymph nodes in the abdomen. So ultrasound, it's really useful for us for looking at the features that can help us to differentiate between TB ileitis and Crohn's disease. So when we have a TB ileitis, very often we will have diffuse involvement and infiltration through all of the layers of the bowel wall, as you can see here. So it's a significant thickening and irregularity. But on this example, we can't really look at the separate layer of the bowel. So it's lots of differentiation of all of the layers. We have a increased vascularity through the whole wall, or increased vascularity in the most lateral or outer part of the bowel. We will have changes in the surrounding mesentery. We will have a wide opening of the IC valve, or we will have a fibrotic changes in the diffuse on the advanced stage of the disease. When we have a Crohn's disease, the Crohn's disease will look completely different on the ultrasound. We also have a thickening and irregularity of the bowel wall. But as you can see here, you can see the separate layer of the bowel wall. All of the layers and stratification is preserved. We will have increased vascularity, but mainly within the abnormal mucosa, and a more linear engorgement pattern into the vascular changes in the mesentery, also in the with the Crohn's disease will have a narrowing and stenosis of the ileocecal valve, when in TB we have, as I said before, it's fibrotic but open IC valve. So ultrasound, very easy test, very widely available, may give us a good indication of the pathology in the ileocecal region. As I say, many of these children, our patients will present in the acute conditions, and when we do the CT, you will see here very abnormal looking cecum extending into the mesentery and involving mesenteric lymph nodes, abnormal appearance of the terminal ileum and cecum, and again, ascites and peritoneal disease in this area. Often, we do MRI in these patients, and again, you will see the abnormality involving the terminal ileum, ileocecal valve, and the cecum. So very often in children, what we like to do it is to make the decision and the diagnosis on the ultrasound, which will be our first imaging modality. And then if we need more information, we will progress to MRI. And you can see here this teenager with very abnormal looking cecum and the terminal ileum and the inflammatory mass extending into the surrounding tissue. And this child was consequently diagnosed with a ileocecal tuberculosis. The least common manifestation of abdominal TB is the visceral disease. It only presents between 10 and 15% of the patients, and very often is caused by hematogenous spread of mycobacteria. Solid organs, the most affected will be genitourinary system, especially with the multiple small abscesses in the periphery of the kidney. It will be liver involvement with the micro or macronodular pattern, spleen, and the pancreas. So when you see special abscesses or nodule, cystic nodule, necrotic nodule in the solid abdominal organs, please think about TB. So this was a very short overview of the abdominal TB. Please remember different aspects, different organs that can be affected by the bacteria. And remember about the high mortality and morbidity of the patient with secondary to the non-specific clinical symptoms. So if you worry and if you have any symptoms that I mentioned in the presentation, please remember of the TB. And remember that multi-intra-abdominal sites are involved in about 50% of the patients. Thank you very much for your attention.
Thank you so much, Dr. Brown, for that comprehensive overview of abdominal TB. We now go on to Dr. Gupta, who will be presenting on AI in pediatric TB. Dr. Gupta, if you can start sharing your screen.
Thank you for being noisy.
Can we please mute the audience? Okay, just a brief introduction of Dr. Gupta. He is a pediatric and onco-radiologist. He has a significant experience in AI and imaging informatics, and he's also a researcher at the All India Institute of Medical Sciences in New Delhi in India. He is also the AI section editor for Pediatric Radiology. Welcome, Dr. Gupta.
Yeah. Hello, everyone. Am I audible and is my screen visible? I hope my
Yes.
screen is visible. Okay.
Thank you
So,
so much.
yes, thank you so much. And hello, everyone. And thank you for joining this symposium from wherever you are in the world. And at the outset, I would like to thank Professor Nasreen and Professor Sodi for the invitation and to the World Federation of Pediatric Imaging for organizing this symposium. So after all the wonderful talks from different speakers about various aspects of pediatric TB imaging, in the next 10 minutes, we will be talking about something that has generated a lot of hype, not only in radiology, but also in our everyday lives. And it has, I think it's safe to say that it has impacted all of our lives. And so the topic that we will be discussing is the role of AI in the field of pediatric TB imaging. I do not have any conflicts of interest to disclose. I don't have any financial relationships with any of the commercial products that have been mentioned in this presentation. And also, in the spirit of the topic, this presentation on AI has also used AI to create some graphics, which I have used to get my points clear. Okay. So this is a brief outline about what we are going to discuss. We'll be discussing why we need AI now and how it's expected to help us, and what are the various challenges and barriers for the implementation of AI or the use of AI, and where do we see this field going from where it is currently. Okay, so so before starting, so this is the QR code which you can scan to have a look at all the references which I've used during this presentation. And worry not, I've kept this QR code in multiple of the upcoming slides, so you can scan it whenever, and you can have a look at the references which I've used and all the resources that I've used for this presentation to have a look at later on. So starting with why do we need AI now? So we have been doing pretty well without AI for so many years. Why do we need it now? To make this point clear, this number keeps popping up in many slides of the previous speakers, and this is such an important number, so I will also use it. So 1.2 million is the number of pediatric cases that were diagnosed with TB in the year of 2024, according to WHO report. So this number, and keep in mind that there are many other cases which have been undetected, which have been missed. So this number tells us the scale of the problem that we are dealing with, and it's worth trying to tackle this problem and trying to use AI to tackle this problem better. Another aspect that has been again previously discussed, especially in Professor Barnard's lecture, was that pediatric TB is inherently difficult to diagnose. Many of the children, they have paucibacillary disease where the number of bacilli are less. The sputum collection process is itself very difficult, and we may not have a hard microbiological evidence, which is more common to have in adult patients. But in pediatrics, the diagnosis becomes inherently hard, and that itself makes the imaging aspect or the chest X-ray aspect much more critical in pediatric TB cases. And because the clinical decision making and the clinical pathway, it hinges more severely or more importantly on the imaging pathway as compared to the microbiological evidence as compared to the adult population. So it's worthwhile trying to use AI to make our imaging pathway better, more reliable, and trying to use it at scale for this problem of pediatric TB diagnosis and screening. Another aspect of pediatric TB, especially AI in pediatric TB, that may not appear very significant at the outset, but if we look at it, it can have enormous consequences. And this aspect is the use of AI in adult TB diagnosis that is pretty mature, and that has pretty much evolved, and that has been deployed at multiple places. So as compared to adult population, the pediatric TB imaging AI is much less developed. So how does it affect children? How does it affect the pediatric population? Because it makes them more prone to be managed with AI tools which have been trained and specifically developed for adult population. And as we will see later in this presentation as well, these models trained specifically on adult data for adult population, they do not do well on the pediatric population. So if such AI, which is already there, which is already mature, is used for pediatric population, it's more likely to do harm than good. And that's another aspect where we need to understand why we need to develop and train more pediatric specific AI models and try to develop this field. So, okay, we need AI now, but in what way can AI help us? And out of all the applications of AI that have been described and that have been explored, the most mature and the most explored application of AI for pediatric TB has been for screening and triaging of the chest X-rays for tuberculosis. So what AI can help us is AI can flag a chest X-ray for the findings of TB or such chest X-rays which need further workup or such children that need, further diagnostic workup for tuberculosis. And more importantly, AI can help us to do it at scale. So this is where the numbers come in and where AI can actually genuinely be impactful as compared to our contemporary practice. So this aspect of AI that is the most explored is the screening and the triaging of chest X-ray, and the AI, the computer-aided detection software, that is the CAD softwares that have been used for TB screening. They mostly look like this. So these images have been shared by Cure.ai. So this is a typical AI tool for TB screening. What it does is it ingests or it takes as input a chest radiograph. And what is the output? The output is the model gives the label that this chest X-ray has signs of TB. But more importantly, it also gives a score. It gives a confidence score in this case, which is quite high, that is 0.99. But the AI model itself gives a confidence score for the presence of TB findings. And this score is important because this score is used for thresholding. So not so a single AI model may be used in different local contexts and for different use cases. You might be using it for just screening normal population. You might be using it for, say, diagnosing children with some symptoms and so on. So depending on the local context and the intended use case, this confidence score will be thresholded, and a certain threshold needs to be defined before we deploy the AI model into a particular setting, depending on various aspects like the program cost or the local context. Okay. Similarly, this is another case which shows the signs. The AI shows that there are signs of TB. We can see some consolidations, and we can say the confidence score of the model, which is quite high. So this is a typical CAD software which are there already in the market. But we will also look at what is the current state of these tools for specifically for pediatric TB. So beyond screening and triage of chest X-ray, what else can AI do for us? AI can help us to diagnose or to classify other chest diseases. For example, like TB versus non-TB, it can help us to classify a pathology as TB versus non-TB. It can also further within the TB patients, AI can help us to classify the tuberculosis itself into, say, active TB versus healed TB, or for example, more severe disease versus less severe disease, and that can help us to prognosticate the patients and to manage the patients better. But these use cases of AI have been less explored, and the most explored application of AI for pediatric TB has been so far for chest X-ray screening. Okay, beyond chest radiographs, what about the other modalities? So AI is rapidly coming up for across radiology modalities, but due to obvious reasons, these use cases of AI are still in the research phase or the exploratory phase. For example, for CT and MRI. So for MRI, we saw from Professor Sodhi's lecture, even human radiologists are still needing to learn more about it. And obviously the CT and MR, they are not as scalable as chest radiograph. So the focus of the AI work has been on chest radiograph. For ultrasound, again, we saw Professor Garcia's lecture. So again, even as human radiologists, we have a lot to learn. And ultrasound is a major modality currently, at least for abdominal and extrapulmonary TB. So again, it has its own shortcomings, but there are AI applications coming up for these modalities and even for newer modalities. For example, cuff analyzer, or for example, a smart auscultation, and trying to diagnose TB with just by using AI for auscultation or for cuff. But these are very exploratory. These are at very exploratory stages right now, and keeping that in mind, we will be focusing on chest radiograph AI applications for the rest of the talk. Okay, so now we understand that AI can help us to scale the chest X-ray screening and for diagnosis of TB, and taking it to the masses. But then more importantly, why it is difficult, why it is hard, and why already AI is not there. So this is an important aspect to understand in this field. And the difficulty for AI in this field boils down to the most major obstacle boils down to data. So data, both the quality and the quantity of data. So for any AI development or any AI training, the first prerequisite is a well-labeled and enough quantity of data. So if we talk about the quality, we saw in Professor Nasreen's talk, so pediatric TB looks very different from adult TB. And because of the different manifestations, just a frontal radiograph may not be enough. And we may also require a lateral radiograph to look at the mediastinal nodes and other imaging findings. So in contrast, most of the AI models which have been trained so far, and a majority of AI tools, they are trained on one type of X-ray, that is a frontal X-ray, and they might not be using the lateral radiograph as well or multi-view AI right now. So that itself is a constraint, and such data is less available right now. And talking about the another aspect of quality of data is the inter-reader agreement. So because the diagnosis itself is difficult, there is no microbiological evidence. So the inter-reader agreement, even among the radiologists, will be very unreliable, and it's itself a difficulty in pediatric TB imaging, and we do not have good labels, and that all boils down to that there is a lack of a gold standard or a proper reference standard itself, which we can use to train the AI. So there is a lack of a well-labeled quality data set because the diagnosis itself is quite difficult. Talking about the quantity of data set, so the number that pops up again and again, that's 1.2 million. It's a subset of the total of 11 million 11 million TB cases that were diagnosed in 2024. So the pediatric TB cases themselves, they are rarer as compared to the adult population. Even if we ignore the scarcity of the pediatric TB data, because of the higher sensitivity of the data, there is restricted access to this data. So that further complicates this, and the scarcity of data. And another important aspect of data is fragmentation, because right now there are so many centers where these children are being treated. And so a lot of the pediatric TB data, it's still siloed, and it remains fragmented within those centers. And there is no good consolidation of all of the data that we have globally for pediatric TB. And thus this restricts the development and the training and the deployment of AI for this use case. And if we try and look for data sets, so there are a lot of open access data sets which are available. And if we try to look for pediatric TB data sets online, you will come across a lot of them. And then if we look at them more closely, what we will see is there are data sets with TB chest radiographs, and there are data sets with pediatric chest radiographs. But the problem arises because the TB chest radiograph dataset is not specific for pediatrics. And in fact, many of the datasets don't even have a label for the age, basically. Is it pediatric or is it adult? So, and in a similar manner, if we look at the pediatric chest radiographs dataset, they are not specific for tuberculosis. They have a lot of other chest diseases as well. So there is a definite scarcity of data, both open access and proprietary data sets, because of the inherent scarcity of data as well as the fragmentation of the data right now, because all these patients are being treated at multiple centers all over the globe. So even if we look through these difficulties and challenges, let's have a look at where we stand currently in the field of AI in pediatric TB. And the most important number that comes up is 15 years. So 15 years is the age cutoff recommended by WHO, above which WHO recommends the use of AI CAD softwares for TB screening. So below the age of 15 years, WHO does not recommend currently any use of AI for TB screening. So this fact in itself tells us that the pediatric TB as a field is much less mature as compared to adult TB diagnosis using AI, even currently as we speak. And that's not just the end of it. There is another step and another obstacle, that is thresholding. Even for adult AI that is more than 15 years, it's not, WHO does not recommend plug and play AI models. It's not like a saying we can just buy an AI model and just start using it for adult TB screening. We have to first do something known as thresholding, and that again comes down to the confidence score that the model gives. And using those confidence scores, we have to first analyze what is the best threshold for our local context, for our program cost, for our intended use case, and then only can we start deploying. Sorry. And then only we can start deploying and start using AI even for adult population. And this is only going to complicate matters for pediatric population, because as you can imagine, a 2-year-old chest radiograph for a 2-year-old is going to look very different than a chest radiograph for a 15-year-old or a 14-year-old. So that will require even age specific thresholds, not just the context specific thresholds, but pediatric TB is going to require age specific thresholds, and that just complicates it even further. But so this is a very good review which I would recommend for you to read if you are interested in knowing about what's the the current status of AI for pediatric TB. And when we go through literature, one message becomes very, very clear and straightforward. And the message is that the adult AI models fail miserably for pediatric TB diagnosis. If we just use and the message that comes out is that one size does not fit all. So, for example, this study, the researchers showed that off the shelf, if we use AI models trained on AI models trained on adult data, if we use the adult AI models off the shelf for pediatric chest radiographs, the researchers showed that the sensitivity was very low, around 20%, with albeit a high specificity. But for a screening task, the sensitivity is much more important, and that showed that. And it's a common message in the literature that the adult AI models, they fail miserably on the pediatric population. So then what else can be done, and what else has been explored to make these models better? So there are several techniques that have been used for on the adult, using starting with the adult AI models and trying to make them better for pediatric population. One of them is something known as transfer learning or fine tuning, where the AI model is further trained on a subset of on a smaller data set of pediatric chest radiographs, and then it has been shown to improve the performance of AI on pediatric chest radiographs as well. Multi-view AI models have been used, wherein both the frontal and the lateral radiographs have been used, and this has been shown to increase the performance of AI. Even further, different newer model architectures, including the vision transformers, they have been used, and using a larger data set, and they have been they've been trained using self-supervised learning, which requires a larger data set. But the researchers have showed that it performs better for pediatric TB detection as compared to the just off-the-shelf adult AI models. So a lot of research is going on into the technical aspects of things as well, and trying to make the models better for pediatric AI population. So bottom line is that currently there is a lack of pediatric specific data models as well as thresholds. And this is what we are dealing with currently. And what is underway? What more are we doing as a community and as a field? So if we look for commercial AI products for TB diagnosis and TB screening, there are many on the market. These are just a few of them. And all these and a few more also claim to be useful or to be valid for pediatric population as well, with different age groups. Some models, some products say age group 4 and above. Some even claim to be useful in infancy, that is less than 1 year old as well, and throughout the age. But the bottom line and the current status is that there is a lack of prospective validation of these commercial products or even the other AI models in the pediatric population. So what is being done in this regard is, so this is one of the global efforts that I came across while I was researching for this presentation. So this is known as CAPTURE, and the researchers here, this is a this is an effort to establish a global pediatric chest radiograph data set, which is curated in a more standardized manner. And the plan is to then evaluate multiple commercial AI products on this standardized data set, and then also use this data set for further fine tuning or further transfer learning of these AI models. But this is an effort which is currently underway. And similarly, another effort is for the prospective validation of AI models. So another important aspect is not just the accuracy or the sensitivity or the specificity of AI, but also we need to see how AI is going to impact the clinical workflow or the clinical decision making. So this is one such study which has been planned and is underway for prospective validation of commercial AI products. And this aims to see how it affects the clinical decision making and how the AI impacts the clinical decision making in a positive or negative way. There are several other efforts even coming in from the vendors as well. For example, this is a study from Cure.ai for where they used enriched data set from pediatric radiographs to further train their AI model, and they were able to show that it had a better performance. Similarly, other efforts like screening of school-based screening in the school, screening in the classroom setting for children, that has also showed for example, the result showed that the number needed to screen was 44, which is quite efficient for a screening program. And also there are efforts for age-specific thresholds and trying to use AI for age-specific thresholds even within the pediatric age group, and trying to make it better. So what comes next? So with all the efforts that are underway for the use of AI, the way I see it, the data that we have already has to be consolidated, and it will be consolidated. But even with there will be a time then, even in fact, this is the time where we have to move on just from radiographs, and we have to go into multimodal data, including the clinical data, lab reports, and all kinds of multimodality data, and trying to diagnose and screen the TB better. Another aspect, what comes in future will be prospective validation, going beyond just the accuracy or the sensitivity or the specificity of AI, and trying to see how AI actually impacts or affects the clinical workflow. And most importantly, what we have to strive towards is an equitable use of healthcare and AI, wherein a pediatric population or the adult population, they have the same amount of benefit from healthcare, irrespective of where they start with. And finally, so the conclusion is that the field where this is going, we have to always keep this goal in mind, that it's not about just training better models and just having models with higher accuracy. The goal is to find and take care of the child that we have been missing with our contemporary ways, and trying to use AI to help us find that child and help that child which we have missed, and to do the screening better. So thank you, and please feel free to connect with me on LinkedIn. And if you are going to be there at the International Pediatric Radiology Congress in June, I will see you in Boston as well. Thank you so much.
Thank you so much, Dr. Gupta, for that comprehensive talk on AI in pediatric TB. We now come to our last speaker, Dr. Gary Paiser. Dr. Paiser, can you load your talk? He's a pediatric interventional radiologist. He studied at Sick Kids Toronto. He's currently a radiologist at the Nelson Mandela Children's Hospital. He's also the academic coordinator of radiology for the University of Witwatersrand, South Africa.
Great, thank you for that introduction. So my talk is going to be the role of interventional radiology in pediatric TB. Like Prof. Mohammed said, I'm Gary Paiser, and I'm a pediatric interventional radiologist at Nelson Mandela Children's Hospital. and I completed a fellowship at the Hospital for Sick Children in Toronto, Canada, in pediatric interventional radiology. And I have no conflict of interests.
Dr.
So,
Paiser, can you load your presentation? We can't see it.
is it not?
No, it's not showing.
Okay, let me try again. Um,
Yes. Can you put it on the slide mode and then we should be fine.
Can you see it now?
Yes, but it's actually showing on your template, so it's not on a slideshow.
How about
Right.
there?
Perfect. Thank you.
Thank you. So, unfortunately, there's a high burden of TB in South Africa in the adult and the pediatric population, and interventional radiology can offer minimally invasive diagnostic and therapeutic options for the care of these children. And in this talk, I'd like to offer practical tips for common procedures, and my focus will be on vascular complications. So, when do you call interventional radiology? If there's diagnostic uncertainty, IR will often perform a biopsy, and also the management of complications, for example, effusions, abscess drainage, and vascular complications. So we often perform a pleural tap for children with effusions related to TB and less commonly chest tube insertions. And image guidance improves the accuracy and decreases the complication rate. So I've added a chest X-ray. You can see some early cavitation here indicating this child has TB, and there's also an effusion. And a pleural tap is often indicated for diagnosis, but we are hesitant to place a chest tube because this increases the chances of empyema, which is a dreaded complication. We would only insert a chest tube if the child is in respiratory distress or if there is a rapidly increasing size of the pleural effusion. Then, in terms of the actual procedure, you do a pleural tap or a chest tube insertion under ultrasound guidance. And I like to hold my ultrasound probe longitudinally so I see the ribs in cross section. You can see the effusion deep underneath here. And there's a propensity for us to hold the ultrasound probe in the intercostal space because this allows us to best visualize the effusion. However, it's very important to be aware of the location of the neurovascular bundle, which is located inferior to the ribs. So if you hold the ultrasound probe longitudinally and you can see the ribs, you know exactly where you would like to put your ultrasound probe to best miss the neurovascular bundle and avoid injury. Image-guided biopsies are also commonly requested. Interventional radiology will biopsy lymph nodes or solid organs. The biopsies offer a high microbiological yield, and it could avoid surgery to obtain your diagnosis. And most of us use a semi-automatic gun. I like to use a biopsy gun that has varying lengths. With children, the anatomical structures are often a lot smaller, so it's nice to be able to have a biopsy gun where you can take a 1.8 or a 2.5 centimeter bite. And if you are dealing with a smaller structure, you can consider a Temno needle, which has a 1 centimeter bite. And in terms of vascular complications, children with TB may present with hemoptysis, and this might be due to bronchial artery hypertrophy, neovascularization, or a Rasmussen aneurysm, which is aneurysmal dilatation of the pulmonary artery. And interventional radiology plays a role in bronchial and pulmonary embolization. So, starting with bronchial artery embolization, what are the indications? Massive hemoptysis, which is an emergency, mild or recurrent hemoptysis, or bleeding that is causing airway compromise. And in adults, we use the measurement of 300 moles in 24 hours as our measure of massive hemoptysis. But children have a much smaller blood volume, so we usually work on 8 moles per kilogram in 24 hours as our measurement of massive hemoptysis. And procedurally, we do a CT angiogram of the chest in everyone. This helps us localize the bleeding, identifies the bronchial artery culprit and its collaterals, and it also reduces the failure rate. So the equipment we would use is a 4 French vascular sheath, which would house a 4 French selective catheter. And the reason why we use a 4 French vascular sheath is the vascular structures of a child are much smaller, and we want to use the smallest vascular sheath that would eventually house a microcatheter. And a 4 French selective catheter is the smallest catheter that can house a microcatheter. And the embolic agent that we usually use are microparticles, and we would use microparticles that are bigger than 350 microns because this reduces non-target embolization. If you are a more experienced interventional radiologist, you could also consider glue. And we would perform this by doing a femoral puncture, doing an aortogram, then selective catheterization of the culprit bronchial arteries, place a microcatheter within those the culprit vessel, and then embolize. And it's very important to understand the bronchial artery anatomy, which is very varied. They usually arise on the aorta at approximately T5 to T6. If you're doing your aortogram, you can look for hypertrophied vessels, which will help you identify them. And it's always important to exclude the anterior spinal artery. And the hairpin sign is important to avoid the artery of Adamkiewicz. So this artery is also known as the anterior radiculomedullary artery. It arises from the lower thoracic or upper lumbar region between T8 and L1, and it supplies the lower cord by joining the anterior spinal artery, and it makes this characteristic hairpin bend as it joins the anterior spinal artery, which I'm outlining here. And every run that you do in a bronchial artery embolization, you absolutely have to be looking out for this hairpin to make sure that you're not going to embolize the spinal cord and cause central nervous deficit. So with regard to the different types of bronchial artery anatomy, there's 4 types, and it's important to understand the concept of an intercostobronchial trunk, which is this vessel, and it splits into the intercostal arteries and the bronchial arteries. And it's easy to identify because the intercostal arteries will follow the intercostal spaces, and then the bronchial arteries will follow the pathways of the bronchi. And in type 1, which is the most common type, there's an intercostobronchial trunk, right-sided, as well as 2 left-sided bronchial arteries. In a type 2, there's a single intercostobronchial trunk and a single left-sided bronchial artery. In type 3, there's an intercostobronchial trunk and a right-sided bronchial artery, as well as 2 left-sided bronchial arteries. And then in type 4, same right-sided configuration, except there's only 1 left-sided bronchial artery. Then the angiographic findings that you may see are hypertrophied arteries, neovascularization, AV shunting, pseudoaneurysms in collateral vessels, and embolization is performed to stasis and loss of vascular blush, and you should always avoid reflux. And we do this by mixing the particles with contrast. And here's an example of a selective catheterization of the intercostal bronchial artery. You can see the intercostal branch here and the hypertrophied bronchial arch here. And then you can see all this neovascularization within the bronchial arteries. Then the complication, the most feared complication is spinal cord ischemia. patients often experience chest pain after embolization, dysphagia, which is often temporary, stroke, very rare, and obviously venous arterial axis complications. And moving on to my final topic, which is a Rasmussen aneurysm. This is an aneurysmal dilatation of the pulmonary artery branches caused by TB, and it occurs in 4% of chronic TB cases, common in the upper lobes, and it's often associated with cavitatory disease. And it's as a result of progressive destruction and replacement of elastic fibers of the pulmonary artery by granulation tissue, which in turn thins arterial walls, and this produces pseudoaneurysms. And the definitive treatment is endovascular embolization. And it's important to note that this is in the pulmonary arterial system. So a bronchial artery embolization won't control the bleeding for a Rasmussen aneurysm. So I've included an example here. You can see this coronal lung window CT. There's this large cavitatory lesion in the left upper lobe as a result of TB. And you get this impression of this dome-shaped soft tissue lesion here at the inferior border of the cavity. And if we change it to a soft tissue window, we can see that this dome shape is in fact a Rasmussen pseudoaneurysm connected to the pulmonary artery. The treatment approach is completely different. As opposed to bronchial artery embolization, treatment for a Rasmussen aneurysm is a venous approach where you puncture the femoral vein, advance your wire and catheter into the IVC, right atrium, right ventricle, pulmonary trunk, and perform a pulmonary angiography, followed by superselective catheterization of the involved vessels. And the embolic agents that we usually use are coils or vascular plugs. And again, liquid embolic agents can be considered for advanced users. And this is just an image of a plug being placed in the pulmonary artery to exclude this pseudoaneurysm. And the take-home message, interventional radiology is essential for complicated pediatric TB, offers diagnostic and therapeutic roles, and early referral improves outcomes. So thank you very much. That's my email. You're welcome to contact me if you have any questions.
Thank you so much, Dr. Peza. Unfortunately, we're unable to take questions due to the time constrictions. I see that we had a problem with the videos not playing in certain of the presenters, unfortunately. You're welcome to type in any further comments, and we will conclude by saying that today is World TB Day. As we conclude the Pediatric Radiology Symposium, we are reminded that imaging plays a pivotal role in the early detection and management of TB in children, often the most vulnerable and hardest to diagnose. Let us carry forward the insights shared today to refine our practice, strengthen multidisciplinary collaboration, and advocate for timely, accurate diagnosis. In doing so, we contribute meaningfully to improving outcomes and moving closer to ending TB in children. I would like to thank all the speakers for their excellent presentations, which really was comprehensive. We do have a number of overwhelming positive comments. And with that, we will close today's symposium. We hope to have the next symposium in 2027 on World TB Day. Thank you, everybody.
Thank you.
What a
Bye-bye.
great symposium.
Thank you,
And
everyone.
I would also like to thank Dr. Jennifer Nicholas, who's the current president of the World Federation of Pediatric Imaging, for the support. Dr. Nicholas, would you like to just add a few words as we conclude?
Well, I'd just like to say it's been my pleasure. This was an incredible symposium, and it's always wonderful to see my colleagues and friends presenting what they're passionate about so that we can work together to improve the lives of children all over the world. So thank you for all the hard work that everyone put into this.
Thank you, everybody. And we maintained our participants throughout the symposium, even though we actually went above time. So that's quite, thank you so much. And a lot of positive comments as well.
I hope to see a lot
Thank
of
you,
you
everyone.
in Boston. Okay.
Thank you.
Thank you,
Bye-bye.
Jennifer.
Thank you.
Bye-bye.
Thank you,
Bye.
Thank
everyone.
you.
Bye.